Yep.
Yeah. Okay, great. So, welcome to your MedSoc cardiology tutorial for this year. I don't know if you guys have been to the other tutorials, but the aim of these tutorials are to just really give you guys high yield information that you'll need for your exams. Now, cardiology is a huge topic, so we won't be able to cover everything. So do go over this again in your own time and watch this tutorial again once you come to exam season. But yeah, hopefully this should serve as a guideline to what you can expect for cardio this year.
Sumayyah, I think you're muted.
Have I been muted that whole time?
No, it was just when you transitioned to the second slide.
Okay, all right. Can you wait one sec? Can you hear me now?
Yes.
Okay, perfect. So I was just mentioning how the core conditions and the presentations are available on your curriculum map on ASR, and that's serves as a really good guide to what you can be expected to know for cardio this year. So in today's talk, we'll split it into 3 parts. The first part I'll do, and we'll go over acute coronary syndromes, hypertension, heart failure. And then part 2, we'll talk about arrhythmias and rheumatic fever, infective endocarditis. And then the third one will be about valvular heart disease, murmurs. If you guys have any questions at any point during the tutorial, feel free to put it in the chat and one of us will pick it up and answer. And like I said, with the SBAs, please feel free to shout out. And if not, one of us will be looking at the chat. I can't see the chat currently, but I'm sure Shazmen or Ameerah can see the chat and help you with that. Okay, so to begin with, we'll start with an SBA. So I'll give you guys like a minute just to have a read of this question and then let me know what you think. Does anyone have any idea?
Stable angina.
Okay, and do you know why you might think stable angina?
Just because the symptoms are exacerbated upon exercise or exertion.
Okay, all right, perfect. So the answer is stable angina. So as you've correctly identified, and we'll go over this when we speak about angina, but the important thing to identify in this question was the fact that he had no symptoms at rest and the pain only came on when he was exerting himself. And that's quite characteristic of stable angina. Now, if we quickly go over the other ones, decubitus angina we'll go over, but it's usually a type of angina that's associated with lying down flat. A STEMI, we can rule this out because the patient doesn't have any pain at rest, and it's not like an acute onset of pain and the pain is not currently there. Pneumothorax, which you will go over in your rest tutorial, but again, it's likely to present with sudden breathlessness and more of a pleuritic chest pain. So pleuritic chest pain is usually when you breathe in and you feel a sharp pain on your chest. Again, this is not what the question is telling us. And then the final one was costochondritis, which is an inflammation of your muscle. And again, it presents with sharp pain on inspiration. So the answer here would be angina, stable angina. So then the first condition we'll talk about today is angina. Now, this is probably the most common complaints you'll see on your cardiology placement. So if we talk about the definition, angina is a symptomatic reversible myocardial ischemia. Now, it has 3 main features which will help you to tell whether a patient's chest pain is angina or not. The first one is a constricting discomfort or pain to the chest, jaw, neck, shoulders, or arms. The pain or the symptoms are brought on by exertion. And the key thing is that the symptoms are relieved within 5 minutes by rest or GTN spray. Now, if a patient has 3 out of 3 of these features, we call that typical angina. If they've got 2 out of 3, it's atypical. And then 0 out of 3 is non-anginal, so we wouldn't class that as anginal pain. Now, I know I mentioned here myocardial ischemia. Myocardial ischemia is just an underperfusion of the myocardium, which can lead to death of the myocardial tissue. Now, in angina, the tissue does not die. It's more so it's starved of oxygen temporarily, and this is what causes the pain. Now, there's different types of angina, which you can see I've listed here. Stable angina is what we're discussing, and it follows the 3 main features. Unstable angina is part of the acute coronary syndromes, which we'll discuss later on, but essentially you can identify it by the fact that it's not relieved by rest. You've got decubitus angina, which we said is pain on lying flat, and then prismental angina, which is a specific type of angina that's caused by a spasm of the coronary artery, which they would kind of hint to in your question or via an ECG. Now, in terms of the pathophysiology of angina, it mainly is related to the atherosclerosis of the coronary arteries. We'll talk about this a bit more in the next slide, but essentially we spoke about how if you have a lack of oxygen reaching the myocardium, that can cause molecules to build up, which can cause pain. Now, angina can be triggered by emotion, cold weather, and heavy meals, and it might also be associated with shortness of breath, feeling sick, sweaty, and then a patient might have like a grey pallor or a faintness about them. So if we go to the next slide and speak about the pathophysiology a bit more. Now, with clinical years, you don't really need to know the pathophysiology of conditions in depth, but it really does help to appreciate how a disease comes about so that you can think about the management and the investigations in a bit more detail. So atherosclerosis essentially is the buildup of fats, cholesterol, and other substances on the artery walls. Now, this buildup is called a plaque. And the presence of a plaque can cause arteries to narrow, which would block blood flow to the heart. Now, stable angina is mostly due to coronary artery disease. So it's when the coronary arteries that supply the heart narrow due to atherosclerosis and plaque formation. Now, when the demand for myocardial oxygen increases with exertion, the narrowed coronary arteries can't meet this demand, and this can lead to myocardial ischemia and pain. Now, the plaque can also burst, which can cause a thrombus, and that can further obstruct blood flow to the heart. So in terms of investigations for angina, and in any condition in fourth clinical years, always use the format of bedside, bloods, and special tests. Now, anytime a consultant asks you what investigations do you do for something, always follow this format, especially in your OSCEs, and you'll always have something to say. So at the bedside, we'll usually do an ECG, and in angina, stable angina, this will typically be normal. However, you might see some ST depression or flat or inverted T waves. In terms of blood, we'll do full blood count, we'll do thyroid function tests. Now, this is to rule out anemia and hypothyroidism because both of them can cause angina. So to rule those out. And then you can also do lipids to assess somebody's patient's cholesterol burden, the HbA1c to look for diabetes, and then UNEs for renal function. Now we come to the special tests, and now this is really what you want to remember for angina and how you can exclude other diseases. So the first line and the gold standard is always a CT coronary angiography. This is non-invasive and involves looking at the arteries in a CT scanner to identify any points of occlusion. The second line, if you still can't exclude angina or diagnose angina, would be non-invasive functional imaging. So that involves either a stress echocardiogram, a cardiac MRI, or a myocardial perfusion scan. Now, the third line, if you still have not been able to diagnose angina, would be a more invasive transcatheter coronary angiography. Now, this is when we're using dyes and etc. to be able to identify any occluded arteries. This is just a picture of a CT coronary angiogram, and you can see the calcification of arteries, and you'd also be able to see if there was a specific blockage. Now, if we go on to the management then, and again, another kind of format that you can use is conservative medical, and surgical. Most conditions will have some type of management under each of these. But again, it just helps for you when you're in an OSCE or when somebody asks you how to manage a condition to use these subheadings. So in terms of conservative management for angina, it involves the optimization of cardiovascular risk factors to reduce the risk of the atherosclerotic process. So for example, we might modify the diet to have less fat. We might counsel them on smoking cessation, reduce alcohol intake as well as exercise. If we move on to medical management, and again, this is really what you want to remember, for symptomatic relief, i.e. in order to relieve the patient when the pain comes on, we'll use a GTN spray. So this is a nitrate, and this helps to dilate the blood vessels to increase blood flow to the tissue. Now, make sure to counsel the patient that they can get headaches and a bit of flushing and dizziness with this. In terms of actively managing the condition, the first line is always either a beta blocker or a calcium channel blocker. Now, this calcium channel blocker would be a rate-limiting one, such as diltiazem or verapamil, and we can speak about that a bit later. But in terms of the indications of when you'd use a beta blocker versus a calcium channel blocker, if a patient, for example, is contraindicated to a beta blocker because they have asthma, we might start them on a calcium channel blocker instead. But for the most part, you can give a beta blocker or a rate-limiting calcium channel blocker. Now, all patients will also be started on a statin. So here we've got atorvastatin, 80 milligrams once in the night, as well as aspirin. And this is to prevent future events, as well as the escalation of angina to full-blown acute coronary syndrome. Now, if the patient is still symptomatic after giving this management, we can give them dual medical therapy with beta blocker plus this time a longer acting dihydropyridine calcium channel blocker, such as amlodipine or nifedipine. We wouldn't be able to give it with the rate limiting blocker, because this is a key contraindication that you should always know, that you can't give a beta blocker as well as a rate limiting calcium channel blocker, because it can precipitate quite dangerous heart block. Now, again, if the patient remains symptomatic, and at this point you'd have specialists involved, other drugs that you can use are isosorbide mononitrate. Now, this one you'd use a standard release drug, as well as having asymmetric dosing intervals. This is something that comes up on PassMed a lot, because patients can develop tolerance to isosorbide mononitrate, and this might mean that they don't get the same effect. So we use asymmetric dosing intervals. You can also use ivabradine, which is a funny channel blocker, and this just helps to reduce the heart rate, so the heart has more time to fill up with blood. And then we've got nicorandil. Now, in terms of surgical management, if the patient's symptoms persist, despite maximal medical therapy, we can give them a PCI, which is percutaneous coronary intervention, which is when we go into the heart and try and remove the blockage. Or if the patient has complex 3-vessel disease, i.e. there's blockages in 3 coronary arteries, we can offer them a CABG, which is a coronary artery bypass graft. So this diagram is just for revision purposes. I've just put it in here just so you can remember what the management is. Like we said, we'd give prophylaxis, and then we've got symptomatic relief, and then your first, second, and third line. It's important for you to know the first, second, and third line, because some exam questions will ask for the first line, whereas in some other exam questions, you might see that they've already tried first and second line, in which case you'd go to third line. Okay, now time for our next SPA. So again, if you guys just quickly have a read of this, I'll give you about 30 seconds. And then if anybody knows the answer, please feel free to shout it out. Anybody want to have a go at this? Is there anything in the chat, guys?
See anything?
Okay, cool. Last chance. Anybody want to try this before I go over it? Okay, cool. I'll just go over it then. So the answer in this case would be isosorbide mononitrate, and we'll go over this. So the patient has presented with chest pain, and it happens on exertion because it's when they're walking up the stairs or walking short distances, and it resolves with rest. Now, the patient has a background of asthma and diabetes and is on salbutamol, saretidine, montelukast, verapamil, GTN spray, and metformin. Now, what's the most appropriate management? So the answer is isosorbide mononitrate. So we'll talk about this in a bit more detail. First of all, the patient's already on first line because I can see that he's on a calcium channel blocker, verapamil. So we're looking at second line medication, which would usually be a combination of a beta blocker as well as the calcium channel blocker. Now, if you guys have identified, he actually has asthma, in which case the beta blocker, so bisoprolol, would be contraindicated, so we can't give that. In terms of referring for angiography, again, we haven't tried maximal medical therapy yet, so we won't refer him to surgery as of now. Ivermectin, you can't actually use that with a rate-limiting calcium channel blocker for the same reason as bisoprolol. It would give heart block, and then we wouldn't switch the verapamil to bisoprolol because it's contraindicated in asthma. So the next would be the isosorbide mononitrate. Okay, cool. So that is stable angina done. We'll move on to our next condition, which is acute coronary syndromes. Now, acute coronary syndromes encompass unstable angina, NSTEMI, and STEMI, so it's a spectrum of disease. Now, the pathophysiology is that it's a bit more, so in stable angina, there was atherosclerosis, which prevented blood flow sufficiently reaching the myocardium. In acute coronary syndrome, usually what happens is we've got a rupture of the fibrous cap of a coronary artery plaque, and then we've got thrombosis and vasoconstriction produced by the platelet release of serotonin and thromboxane, A2, and inflammation. And this means that there's, depending on whether it's unstable angina, NSTEMI, or STEMI, there's almost an absolute decrease in blood flow to the myocardium. So the patient will present in a similar way. So you've got acute central chest pain, which might radiate to the jaw, the shoulder, or the arm, and it usually lasts more than 20 minutes and is associated with breathlessness, as well as autonomic symptoms such as nausea, dizziness, sweating, and shortness of breath. Now, it's important to know the risk factors, and I kind of always group my risk factors into unmodifiable and modifiable, and this just helps in the patient counselling and in the conservative management. So I'm not going to read these all out, but you guys can have a look at some of the unmodifiable risk factors for ACS as well as the modifiable ones. Now, something that's quite important to note is that in elderly or diabetic patients, we might have something called a silent MI, which is when they have acute coronary syndrome as identified by ECG or the blood results, but it presents without chest pain. So it's important to be aware of this in diabetic patients. They might actually present with something like epigastric pain or pulmonary edema, etc., in which case that still might be an indication for us to test for ACS. Now, unstable angina would be an acute central chest pain that comes on at rest, and it has all these, you know, the over 20 minutes and the radiation and etc. However, the ECG can be normal or abnormal, but the most important thing is that there is no troponin rise. We'll talk about troponin in a bit, but that's how you would identify unstable angina. In terms of an NSTEMI, again, you'd have the acute central chest pain at rest, radiating to the left jaw, arm, and shoulder that lasts over 20 minutes. However, you would see ECG changes, and you would also see a troponin rise. And then a STEMI, you can see the very characteristic specific ECG change, as well as the troponin rise. So in terms of the investigations and diagnosis for acute coronary syndromes, it's pretty much the same process, and then from the results that you get, you can kind of distinguish which exactly it is. So investigations and diagnosis, again using the same format, the bedside blood and imaging. At the bedside, we do an ECG. In terms of bloods, we'll do our standard full blood count, thyroid tests, E's and E's, lipids, etc. And then the most important is the cardiac biomarkers. Now, Troponin is an enzyme that's released upon myocardial necrosis. So when the myocardial cells have been starved of oxygen and died as a result, they can release their intracellular contents, and this will include troponin enzymes. Now, in unstable angina, there is a rupture of the plaque, which causes thrombosis and vasoconstriction, but there's not complete stenosis of the coronary artery. So it's ischemic, but not necrosis, and that's why the troponin would not rise, because the cells have not died as of yet. You might see these changes in the ECG, such as ST depression, but the key thing is that the troponin does not change. In an NSTEMI, on the other hand, you've got severe but incomplete stenosis. So some cells will die, and as a result, you'd see some troponin rise, as well as the ECG findings. And then in STEMI, there's severe and complete stenosis of the artery. So as well as a rise in troponin, you'll see very characteristic ECG changes, such as ST elevation, or a new left bundle branch block, or like hyperacute tall T waves. Just a quick point here, if a patient is having a posterior STEMI, i.e. a myocardial infarction at the back of their heart, it might present with ST elevation in V7 to 9, which is not typically seen in a standard ECG. Now, one other thing to remember is that troponin can actually rise with other causes of myocardial damage, such as myocarditis or pericarditis. However, with these conditions, the troponin levels are likely to change little hour by hour, whereas in an MI, if you take serial serum troponin levels between 3 to 12 hours, you'll see that the troponin will continuously rise. So with the other conditions, the troponin does not rise too much, but with ACS, namely NSTEMI, you will see the troponin rise, and it falls back to baseline after like 5 to 14 days. Now, quick thing, the note here about creatine kinase, if a patient is presenting with acute coronary episode, having already had another episode within the last week, their troponin will already likely be high from the previous insult, so you won't necessarily be able to rule it out. In which case we'd look at something called CKMB, so creatine kinase. And the reason why is this also increases in ACS, but it returns to baseline within 2 to 3 days. So if it rises again, that would be an indication that the patient is having an ACS. And then in terms of other imaging, we might also do an echo and X-ray, but the troponin and the ECG should help. Now, in terms of ECGs, I think there was a tutorial already done about ECGs, so I won't go into this in more detail, but this is just my notes on how I approach the ECG. So looking at the rate, the rhythm, and then looking at each parts of the P wave, PR, Q wave, QRS complex, QT interval, ST segment, T wave, and U wave. Now, the important thing about ECG is quite important in ACS to be able to localize an infarct. Now, what I mean by that is, depending on where you see the ECG changes, so which lead you see it, you should be able to identify the corresponding coronary artery that supplies that part of the heart. So here we can see that the anterior heart is supplied by the left anterior descending artery, and the changes would be in V1 to V4, so V1, 2, 3, and 4. The lateral part of the heart is supplied by the left circumflex, which we can see on this diagram here. And that would be changes in leads 1, AVL, V5, and V6. The inferior heart is supplied by the right coronary artery, and this becomes important later on, which we'll talk about. And this can be seen in leads 2, 3, and AVF. And then posterior is V1 to V3, and we'd see reciprocal changes. So for example, we might see ST depression instead of ST elevation, and this area is supplied by the right coronary artery as well as the left circumflex. Now, if we move on to our next SPA, then that leads on from this localizing the infarct part. So have a read of this SPA. I'll give you 30 seconds, and then I will get, if you know the answer, please do shout it out. Does anybody want to have a go? Don't be shy, guys. Okay, cool, that's fine. We'll go over it then. Okay, so the answer is 4, so leads 2, 3, and AVF, and we'll go over why. So the question is essentially asking us that a patient has presented with ST elevation myocardial ischemia, and notably, they've also got a very low heart rate, so they're in first-degree heart block following this MI. Now, if we know the localization of our infarct and the coronary arteries that supply the heart, a key thing to note is that the right coronary artery actually supplies the AVN node. And so if the right coronary artery, which is seen in leads 2, 3 AVF, becomes occluded, that can lead to bradycardia. And that's a key exam question that they love to ask a patient who presents with bradycardia after a heart attack, which artery has been affected? And the answer is the right coronary artery, as seen in these leads. Okay, so let's move on to the management now then. In terms of STEMI, a STEMI is an emergency, so we need to deal with it ASAP. And you should do your, ABCDE as you would Dr. ABCDE with any emergency. We'll always start by giving oxygen. However, this is only if their SATs are below 94%. We wouldn't give it. NICE says to not give it if the SATs are above this. Now, with things like this, it's really important to look at the NICE guidelines, especially if you've got a really high yield topic such as ACS or emergencies. Have a look at the NICE guidelines, and the NICE guidelines can sometimes be long, so you can also look at CKS, which is the clinical knowledge summaries, or even in QuesMed, to be honest, or PassMed for that matter, they usually summarize the NICE guidelines. So this is a mnemonic I use to kind of remember what we needed to do for the for STEMI management. So we'd immediately start ACS protocol, and what this involves is that we always need to give. The priority is always to revascularize, i.e. open the vessel that's been blocked. And the way we do that is percutaneous coronary intervention. And this is the gold standard for someone with acute STEMI if they are presenting within 12 hours of the onset of their symptoms, and you can provide the primary PCI within 120 minutes of their first medical contact. So if a patient has presented and we can't get them to a PCI center within 2 hours, we wouldn't offer it, in which case we'd need to offer something else, which is fibrinolysis. So like we said, after oxygen, if they need it, we'd give the PCI, as well as all patients are given a stat dose of 300 milligrams of aspirin, and this is continued indefinitely. And then, as well as the revascularization, we'd also start them on dual antiplatelet therapy. So we'd give them antiplatelets such as ticagrelor or clopidogrel or prasugrel. And in terms of which one we use at which time, I think PassMed goes into a bit more detail. For the purpose of time, I won't be able to go into that. And then nitrates. Now, GTN is not routinely used unless the patient is very hypertensive or in acute left ventricular failure. So we mentioned that the gold standard is PCI. If a patient is having a PCI, then remember that you always need to give them unfractionated heparin, as well as the bailout GPI, so a glycoprotein inhibitor, if we're using radial access, i.e. we're going through their radial artery. But if we're using femoral access, we give them something called bivalirudin and bailout GPI instead. And this is all on PassMed. So we'd start prasugrel if they're not already on an anticoagulant. If they are, then we'd give them clopidogrel. In terms of if we can't fulfill these criteria for the PCI, we'd offer them fibrinolysis with something called autoplase. So this is basically when we give a drug that breaks up the clot. And after we've done fibrinolysis, we need to recheck their ECG after 90 minutes. And if there's no resolution, we need to give them a PCI. And if they have multivessel disease, then we can consider them for a CABG. Quick thing to note is that if we do a PCI and we need to use a stent, then we usually use something called a drug-eluting stent in this case. Okay, cool. So that was STEMI. In terms of NSTEMI and unstable angina, because you can't differentiate between the two immediately because they present the same and it would take time for the troponin to come back, you'd commence ACS protocol for both if you suspect either of these. And what that includes is you'd give them 2.5 milligrams of fondaparinux, which is an anticoagulant. You'd give them their stat dose of aspirin, so 300 milligrams, as well as stat dose of another antiplatelet, such as ticagrelor, 180 milligrams. You'd also give them a GTN spray for their immediate symptom relief. You'd give them morphine if they were in severe pain, and then you might give them some metoclopramide, which is an antiemetic if they feel nauseous. Oxygen, again, if their SATs are below 94%, and then you might, beta blockers might also be indicated. Now, once you've acutely managed the patient would then have a cardiology review. And for this, we do 2 scores. The first score is a heart score. Now we work out what their 6-week risk of major cardiac event would be. And if this was high, we'd admit them. If it wasn't, we'd discharge them. And we'd also look at their GRACE score for their mortality in 6 months. Now, if they have a low risk and they have no further chest pain, their ECG is normal and no signs of heart failure, then we'd consider discharge, cardiac rehab, and then secondary prevention. If they're medium or high risk, i.e. more than 3%, then we need to give them a PCI within 72 hours. And then you'd also give them unfractionated heparin for this, as well as the GPI inhibitors that are mentioned here. Okay, so this is the immediate management of ACS. After you've managed STEMI, NSTEMI, and unstable angina acutely, you also need to talk about secondary prevention. So this is after you've managed them, what can they do in the future to prevent them from getting ACS again? Now, we'd want to do things such as modifying their risk factors. So again, smoking cessation, healthy diet, exercise, etc. And then we'd optimize their cardioprotective medication. And I always remembered this with the 6 A's. So we'd continue them on aspirin, but we'd give a lower dose of 75 milligrams. We'd continue them on another antiplatelet. So they'd have dual antiplatelet therapy. And this can either be clopidogrel, 75 milligrams, or ticagrelor. Sorry, I think I've spelled this wrong. I need to change this. You'd also give them a beta blocker. So I remember with atenolol or calcium channel blocker, and this is indefinite if the ejection fraction is reduced. Otherwise, it's for 12 months. An ACE inhibitor in those with left ventricular dysfunction or hypertension. An ARB, such as eplerenone, if they've got heart failure, and then a statin. So, for example, atorvastatin. And then we'd discharge them. So we'd safety net them, continue their fondaparinux until their discharge, give them driving advice, and give them advice on returning to work. And I think these pages are available on PassMed as well. Okay, so moving on, a key thing that you should know about is the complications of an MI and the key words that might come up in an exam. Now, I don't want to go over all of these in too much detail. When you have the slides, you can look over them. But some key things is that if a patient is in an exam question presenting after an MI and they've unfortunately passed away, the key reason for cardiac arrest is ventricular fibrillation. So this is with an very irregular rhythm, and we'd manage this with advanced life-saving protocol. Another one is pericarditis. So usually it occurs in the first 48 hours, and it's quite a typical pain, i.e. it's worse when they're lying down. We've also got Dressler's syndrome, which is similar to pericarditis, but it occurs 2 to 6 weeks following the MI. And the patient might present with fever and raised inflammatory markers, and it happens because of an autoimmune reaction against the antigens during myocardial recovery, and we treat this with NSAIDs. Other key ones are VSD and acute MR. Now, it's quite important to know the murmurs that these might present with. So, for example, a VSD might have a pansystolic murmur, whereas an acute MR might have an early to mid systolic murmur. And these are key terms to remember when you have an exam question. I won't go over this in too much detail. Okay, so we'll move on then to our next condition, and our next condition is heart failure. Again, another very high yield condition. So heart failure, also known as congestive heart failure, is defined as the failure of the heart to generate a sufficient cardiac output to meet the metabolic demands of the body. And it can be classified in many different ways. So you can have low output, high output, left versus right, systolic, diastolic, acute, chronic. And these all confused me a lot. But I think hopefully from this tutorial, you'll be able to see that the key differentiation is the acute and the chronic heart failure. And then chronic heart failure can either be predominantly like systolic or diastolic. And these can sometimes be used interchangeably with, for example, reduced ejection fraction, preserved ejection fraction. So high output heart failure is essentially when there is an increased metabolic demand that the heart can't meet. So for example, the patient is pregnant or they've got anemia, they've got an increased metabolic demand and the normal heart is not able to meet this and the patient is thus in high output heart failure. Low output heart failure is much less common. It usually occurs when there's a primary problem with the heart. A systolic heart failure would be when there's an impairment of ventricular contraction. So the ventricles can fill, but the heart can't pump because of impaired contraction during systole. And this can be caused by, for example, dilated cardiomyopathy, ischemic heart disease, myocarditis, etc. As a result, the ejection fraction of the volume of blood that's being pumped out of the heart will be reduced. Diastolic heart failure, on the other hand, is when the ventricles can't relax and fill properly. Hence, the heart still can pump blood, but it pumps out less blood per contraction due to reduced diastolic filling. And this can be caused by, for example, hypertrophic obstructive cardiomyopathy or other cardiomyopathies, cardiac tamponade, restrictive pericarditis. So you've got your reduced ejection fraction because the heart can't pump out enough blood, preserved ejection fraction because the heart can pump, it's just that less blood is entering it. Now, in terms of the pathophysiology, you don't need to know it in much detail, but it's just, initial myocardial insult that results in a neurohumoral activation that can cause wall stress, dilation, and ventricular remodeling, which leads to a failing myocardium. The key thing is the acute versus the chronic. Acute just means new onset heart failure or an acute deterioration. Chronic is long-term, and then left versus right just refers to the side of the heart. In terms of the presentation and pathology, I remember it with left heart failure predominantly affecting the lungs because that's where the blood is going, so where the blood is backing up. And then the right heart failure, the blood would congest the rest of the body. So in left heart failure, we predominantly have pulmonary congestion, and that can present with symptoms such as exertion dyspnea, i.e. shortness of breath when they're trying to do something, or orthopnea, so shortness of breath when they're standing up, or paroxysmal nocturnal dyspnea. You might see it in an exam question by someone waking up at night, gasping for breath, or using 2, 3, 4, 5 pillows to prop themselves up at night to help them to breathe. And then you've also got systemic hypoperfusion, which can result in fatigue and hypotension. On the other hand, we've got right heart failure. So if you've got a failure of the right side of the heart, you're going to have backflow to the rest of the body, and this can cause systemic congestion, which can result in symptoms such as cardiac cachexia, abdominal distension, venous congestion, ankle swelling, weight gain, abdominal swelling. Signs include a raised GVP or pitting edema, okay. Now we've also got the NYHA classification of heart failure here. It just classifies the degree of heart failure depending on whether the patients are comfortable at rest or whether they're symptomatic at rest and on physical activity. The worst would be class 4, where they've got shortness of breath and symptoms at rest without any physical activity. And then class 1 would be they have heart failure, but they haven't got any undue shortness of breath from normal activity. Okay, so if we then move on to investigations and diagnosis, again, using the bedside bloods and imaging rule, the bedside we do an ECG, you might see things such as hypertrophy, ischemic changes, if that's what caused the initial insult. For bloods, we do Usinese, LFTs, glucose, lipids, etc. But the gold standard is to look for the NT-proBNP. So this is released by the ventricles in response to myocardial stretch. It has a negative predictive value, which means that if the proBNP is low, it means that heart failure is very unlikely. Now, if the patient has got very high levels of NT-proBNP, so more than 2000 pg per mil, then we'd need to refer them for specialist assessment and a TTE or a TOE within 2 weeks. If it's raised, i.e. between 400 and 2000, we need to still do a specialist assessment, but this can happen within 6 weeks. And if the NT-proBNP is less than 400, then heart failure is quite unlikely. We can also do an imaging. So the gold standard would be an echo, and we can measure the ejection fraction here to classify the reduced versus preserved ejection fraction. We can also do an X-ray, which we'll go into a bit more detail in a few slides' time. There's a specific presentation of heart failure on X-ray, as well as any functional tests. Just quickly here, there's a difference between first line and gold standard. First line is what you would do first. Gold standard is like the thing that will help you to diagnose the heart failure the best. And these are not necessarily always the same. Okay, next SBA then. Just have a quick read of this, and then if anybody wants to shout it out, feel free. If not, I'll just go over it in about 30 seconds. Okay, anybody want to have a go? No? Okay, we'll go over it. So the answer here would be chronic kidney disease. Now, if we look at the question, the patient is a 70-year-old woman. She has a past history of hypertension. She's got 2-month history of increased dyspnea, and her shoes have become tighter, which might be indicating to me she's got some ankle swelling. Now, we're suspecting heart failure. We order a BNP test. What can confound a high BNP result? So these are all things that can confound it, but obesity, the ACE inhibitor use as well as beta blocker use actually can lower the BNP. Now, I didn't go into this in too much detail, but it's important for you guys to understand the renin, angiotensin, aldosterone system for how it can regulate stretch of the myocardium and the blood pressure. And this will help you to identify in a bit more detail why these can lower or increase the BNP. The answer is chronic kidney disease because BNP is a protein which is obviously excreted by the kidney. If you've got kidney disease, you're going to have reduced excretion, and therefore you're going to have a high BNP result, which would be a confounding. Okay. Now, I mentioned the ABCD of heart failure. This can come up for you in an OSCE. You might be given patient symptoms and then an X-ray and have to explain it. So always, follow the structure for describing an X-ray. For example, checking the patient's name, doing the RIPE, the rotation, the inspiration, the projection and exposure. But in terms of the features, the ABCDE mnemonic is quite nice to remember. The A stands for alveolar edema. So you've got fluid in the alveoli, and that can present with bat wing opacities. You've got curly B lines, which are caused by interstitial edema, so fluid moving into the tissue. You've got C for cardiomegaly. The heart, the cardiothoracic ratio should be less than 0.5 in an X-ray. If it's more than 0.5, i.e. is taking up more than half of the image, you've got cardiomegaly. D stands for upper lobe, dilated upper lobe. So you can see that the vessels appear larger than normal. And then E stands for pleural effusion, which might present with like meniscus-shaped contours in this region here. Okay. Another SBA for you guys. Which of the following drugs has been shown to carry a mortality, not been shown to carry a mortality benefit in those with heart failure? I'll give you 30 seconds. If anybody answers, you can feel free. If not, I'll just go over it. Anyone want to have a go? No? Okay, in the interest of time, I'll just go over it this quickly. So this is a very common question that comes up in exams about mortality benefit. The answer is furosemide. So furosemide is a diuretic. It doesn't have any long-term reduction in mortality. However, it can help symptoms. The way I remember the drugs that improve mortality in heart failure is with this mnemonic BASH. So B for beta blockers, A for ACE inhibitors and ARBs, S for spironolactone, and then H for hydralazine with nitrates. The other four would have a mortality benefit, i.e. they would improve mortality in patients with heart failure. Okay, moving on then, if we quickly discuss the management for chronic heart failure. Again, this is an algorithm that is quite important to remember. I've presented it here. You guys can, use this or the NICE guidelines, etc. So the first line is always an ACE inhibitor and a beta blocker. So for example, bisoprolol, and then you would start them with an ACE inhibitor. Start them one at a time. If they're still symptomatic, you can give them dual therapy. Second line, if their symptoms are not controlled, would be an aldosterone antagonist. If it's not controlled with an ACE inhibitor and a beta blocker. However, this is only if their potassium is less than 4.5. If it was more than 4.5, you'd go for like an ARB or the hydralazine and nitrate. You might also start them on a loop diuretic such as furosemide to give them symptomatic relief and just to stop the fluid overload that might be causing their breathlessness. But remember, this would only improve symptoms. It wouldn't affect their mortality. Now, if the patient is still symptomatic after first line and second line therapy, you'd move on to third line therapy, which would require the input of a specialist. So third line therapy includes stuff such as ivabradine. So the patient's already on an ACE inhibitor and a beta blocker. But you can only give ivabradine if their heart rate is more than 75 and their left ventricular ejection fraction is less than 35%. These would be the indications. You can also give other drugs such as digoxin. It's quite useful if the patient has coexistent atrial fibrillation, but otherwise it's kind of last on our list. You can also give drugs such as sacubitril valsartan or hydralazine and nitrate, especially if they're Afro-Caribbean or they're intolerant to ACE inhibitors or beta blockers. And then finally, if they're still symptomatic, you'd start like cardiac resynchronization therapy if they've got a prolonged QRS interval. So that just involves using devices to regulate the heart rate in a patient. You'd also offer all patients an annual influenza vaccine as well as a one-off pneumococcal vaccine. Remember this because exam questions ask this a lot. You'd also want to treat their cause, i.e. what caused their heart failure, whether it was MI or valve disease. And then you'd avoid exacerbating factors such as anemia, thyroid dysfunction, which we know can contribute to heart failure. We'd want to manage these for the patient. Okay. Now, if we go on to acute heart failure, then acute heart failure, as we mentioned, is used to describe the sudden onset or worsening of symptoms of heart failure. So they might have a background history of heart failure or they might not. It just depends. If they don't, it's called de novo heart failure. So increased cardiac filling pressures for whatever reason has resulted in myocardial dysfunction, or decompensated, which is when they already have heart failure, but it suddenly got worse. And it's usually due to things like acute coronary syndrome, arrhythmias, and hypertension. To investigate this, again, bedside blood imaging. At the bedside, we'll do ECGs to see if they have any arrhythmias or ischemia we can identify. For bloods, we do an NT-proBNP. If it's more than 100, that indicates myocardial damage. We also might do their troponin and electrolyte abnormalities, and then imaging. So an X-ray would show the ABCDE features. An echo might show left ventricular dysfunction. Now, a patient with acute heart failure or pulmonary edema might present with symptoms such as breathlessness, reduced exercise tolerance, peripheral edema, fatigue. And signs, now quickly, symptoms are what the patient presents with. Signs is what you'll find on examination. Signs might include cyanosis, so they might be a bit blue. Tachycardia, they might have a very fast heart rate. Elevated JVP, particularly if they look to the left, I think. Orthopnea, displaced apex beat, bibasal crackles, and you might also hear a third heart sound. Okay, so in terms of managing acute heart failure, this is what we'd follow. So again, you want to sit the patient upright always. Sometimes the exam questions will give you this as an option. And if they haven't already sat the patient upright, always sit the patient upright. This just helps to prevent the fluid from accumulating in the whole area of their lungs. You'd give them immediate IV furosemide, so 40 to 80 milligrams slowly. You'd also give them oxygen only if their SATs were low, because otherwise you can cause a vasoconstriction, which leads to low carbon dioxide. You also would, I think PassMed says to start a nitrate infusion. However, it's not routinely offered according to NICE, but if they've got concomitant MI or severe hypertension or regurgitant aortic valve or mitral valve disease, then we'd give them the nitrate infusion. However, a major contraindication or side effect is hypotension, so be careful in these patients. Now, if you've given the loop diuretic, sat them up, give them oxygen, etc., and it still hasn't improved, you might consider CPAP. So this is particularly if they're in respiratory failure. This will help them to recruit the alveoli and drive fluid out of the alveolar spaces into the vasculature so they can breathe properly. And you can use this mnemonic LUMNOP to remember. So loop diuretic, morphine if they're in pain, nitrate, again, we said they're not routinely offered, but if they've got any of these categories, then you can. Oxygen if their SATs are low and then their position, i.e. sit them up. We'd also monitor them, so we want to do their new score at least 4 times a day. We want to do daily weights, aiming for a reduction of 0.5 kilograms per day because these patients will be heavily fluid overloaded. We want to repeat their X-ray, and then eventually we'd want to wean them off the IV medication into oral or bumetanide. And then if they have got a very low ejection fraction, then we might consider starting them on ACE inhibitors, etc. Okay, so that wraps up heart failure then. Sorry, that was a really speedy run through, but hopefully when you guys look through at the slides, it will help. The final thing that I'm going to cover today is hypertension. So bear with us, guys. This is going to be a pretty long tutorial, but cardio is quite a big topic. So yeah. So hypertension is defined by NICE as a clinical blood pressure or clinic blood pressure that reads persistently above 140/90 millimeters per millimeters of mercury, or a 24-hour average home or ambulatory blood pressure reading of more than or equal to 135/85. So if a patient presents to you in clinic with a high blood pressure that's persistent, you'd always need to check on 24-hour monitoring. And if they have above this, then we can diagnose them with hypertension. Now, hypertension can be primary or secondary. Primary predominantly affects the elderly, and it's the most common one. It's about 95% of cases, and it's usually idiopathic, i.e. we don't know what the cause is, in comparison to secondary, which have specific causes. So for example, renal causes might be coronary kidney disease, chronic kidney disease or glomerulonephritis. Endocrine causes might be Cushing's or Conn's or pheochromocytomas, and then other causes such as pregnancy, NSAIDs, the active pill or glucocorticoids. These can all increase your blood pressure. Now, hypertension is usually asymptomatic, but if it persists for a long amount of time, the patient might experience headaches, visual disturbances, as well as in the most extreme cases, seizures. Quick note about malignant hypertension here. So if you're in a clinic and a patient presents with a rapid rise in blood pressure or a blood pressure over 180 over 120, and they've got an acute impairment of one or more organ systems, so they've got end organ damage, then they need to be dealt with as a matter of emergency. But I won't go into the management here. I think this might be covered in your acute lecture. Okay. So in terms of investigating hypertension and diagnosing it, the first thing you need to do is you need to confirm that they've got hypertension, because often patients might actually present with a higher blood pressure in the clinic, and this is called white coat hypertension. So you confirm it in clinic with 2 measured blood pressures over 140/90, and then you'd also give them 24-hour monitoring at home. And if this persistently was over 135/85, this would be sufficient for diagnosis of hypertension. In these patients, we also want to monitor their end organ damage. So do a fundoscopy to make sure they don't have any hypertensive retinopathy. Check their kidney function with urine dipstick, because we don't want any protein in the kidney, but if they've got persistently high blood pressure, you might see some protein. Also do their blood glucose, lipids, etc. And then have a look at their ECG as well. You might see there might be an increased strain in the heart that might cause hypertrophy. And then once you've diagnosed them, always check their Usenis, lipids, ECG regularly, etc. Now, in terms of the type of hypertension they have or the stage of hypertension they have, this is quite important because it actually determines management. So stage 1 hypertension would be a clinic blood pressure that is more than or equal to 140/90, as well as a home blood pressure of more than or equal to 135/85. Stage 2 hypertension would be a clinic blood pressure of more than or equal to 160/100 millimeters of mercury, and then a home blood pressure of 150/95 and more than or equal to. Now, these numbers are important to remember because, as I said, they determine management, which we'll discuss on the next slide. So just keep these in mind. And then stage 3 hypertension would be if their clinic systolic blood pressure is more than or equal to 180, or their clinic diastolic is more than or equal to 110. Now, once you have diagnosed them, you need to see, okay, do we treat them or not? So if it is below 135/85 at home, then they haven't got hypertension. So just monitor them and make sure, you know, they have good lifestyle management. If you have seen this clinic reading and you offer them ambulatory blood pressure monitoring and it's more than or equal to 135/85, i.e. they've got stage 1 hypertension, you would only treat it if they are less than 80 years old and they've got some sort of target organ damage, they've got a 10-year QRS score of more than or equal to 10%, they've got renal disease, diabetes mellitus, etc. The reason why they need to be less than 80 is because as you get older, your arteries will calcify more anyway, so your blood pressure will be higher, and we often do need a high blood pressure to kind of make sure that the blood is pumping to the body sufficiently over that age, so we wouldn't treat it in people over 80. For the most part, most of your patients that you see with stage 1 hypertension will have some sort of cardiovascular risk factors or diabetes, in which case we would most likely treat it. But yeah, just remember these are the things that we need to make sure that they have. In terms of stage 2 hypertension, so for example, a home reading of more than 150/95, we treat all patients regardless of their age and existing comorbidities. With stage 3 hypertension, i.e. very severe, we need to treat it immediately. So if we see signs of end organ damage such as retinal hemorrhage or papilledema, new-onset confusion, chest pain, etc., we'd admit them for specialist assessment straight away. If they don't have the hemorrhage and the papilledema, confusion, etc., then we'd arrange the urgent investigations and if possible, start the treatment immediately. And as always, we'd give the patient lifestyle advice such as weight loss and healthy diet, you know, reducing the salt and saturated fats, and reducing alcohol and caffeine, etc. Okay, so moving on then to the management of hypertension. So again, this is another algorithm that you have to remember, and it's quite nicely presented here. If a patient is less than 55 years old, or they're type 2 diabetic, so they can be over 55 in this case, we'll start them on an ACE inhibitor or an angiotensin receptor blocker. If, however, they are over the age of 55 or 55, they don't have type 2 diabetes mellitus, or they are Afro-Caribbean, we would start them on a calcium channel blocker. But importantly, if they are Afro-Caribbean, but they do have type 2 diabetes mellitus, then we'd move here and we'd give them preferably an angiotensin receptor blocker over an ACE inhibitor. And the reason of this is unknown, but I think it's something to do with the renin levels in people of Afro-Caribbean descent. Now, so that's step 1. If they still are not adequately managed with monotherapy, you'd move on to dual therapy. So for example, you might give them an ACE inhibitor and a calcium channel blocker, or an ACE inhibitor and a thiazide-like diuretic. Step 3, if they still have not managed their symptoms adequately, you'd give a combination of the 3. And then step 4, if the patients are still hypertensive, we'd look at their potassium levels. And if it was less than 4.5, then we might start them on a spironolactone, so an MRA. But if it was more than 4.5, we wouldn't be able to give spironolactone because spironolactone can cause hyperkalemia, which is dangerous to the heart. In which case we'd either give them an alpha or a beta blocker. And remember, you know, if they have asthma or etc., you wouldn't be able to give them a beta blocker. If still their blood pressure is not controlled, then we'd need to refer them for specialist review. It's important to know that ACE inhibitors are actually contraindicated in pregnancy. So if you've got a pregnant patient with hypertension, you wouldn't start with an ACE inhibitor. You would start along this line, irrespective of whether they were less than 55 and type 2 diabetic. Okay, so that covers the management. The final SBA then from me, have a read of this. I'll give you guys 30 seconds, and then if someone wants to shout it out, please do. If not, I'll quickly go over it. Okay, cool. In the interest of time, I'm just going to go over it. So the question here, you've got a 70-year-old man to come to the GP. He's complaining that his ankles have been more swollen recently. His past medical history includes hypertension and osteoarthritis. He can't remember what medications he's taking, but he has been started on a new antihypertensive, having taken beta blockers for several years. What is causing his new symptoms? So he's talking about his ankles being swollen more recently. And again, this is just something you have to remember. The answer is amlodipine. So amlodipine can cause peripheral vasodilation, which can reduce the systemic vascular resistance and result in swollen ankles and headaches. You can also rule out the other ones. For example, we know they would have never started him on verapamil because he's on beta blocker and we don't want, you know, asystole. Propranolol, he's already on a beta blocker, so he wouldn't be, you know, started on propranolol again. And then it's not Ramipil or losartan because they don't cause ankle swelling. Okay, so that's it from me. Before Shazmen or Ameerah start, please can you guys just take a few minutes to fill in the feedback form, just so we know how we can improve these tutorials. But yeah, thank you very much, and I'll hand over to the other girls.
Hello everyone, so I'm going to take over now. Sumayyah, is it okay if I take control of the presentation? Wait, Sumayyah, do you want to keep on presenting or?
No, I've stopped sharing, so go ahead.
Okay, sure. 1 second, let me just pull it up. Just 1 second, guys. Okay. Can everyone see my screen?
Yes.
Lovely. Okay, guys, so I'm going to be speaking about heart block and a couple of other things. Let's start with heart block. So heart block occurs because of a defect between the atria and the ventricles, and commonly that's because of a defect in the atrioventricular node. So it just somehow stops passing electrical activities. Really important to note that heart block is different from bundle branch blocks. So bundle branch blocks occur because of defects in the His or Purkinje system, whereas heart blocks is just the AVN. And heart block can be classified into a couple of different types. First, you have first-degree heart block. This is where you have a prolonged PR interval, but it stays constant throughout the ECG strip and you don't have any missed heartbeats. So by prolonged, we mean that it's more than 120 to 200 milliseconds. By PR interval, we mean the start of the P wave to the beginning of the QRS complex. So this can be a normal variant in people that are young or athletic. So basically people with high vagal tone. And usually it's not something we're too concerned about, but it can in some cases indicate that the patient has some cardiac pathology. So we will only treat them if they are unstable, hemodynamically compromised. Just here at the bottom, I've included a few other normal ECG variants. So they include bradycardia, so slow heart rate, first-degree heart block, morbid swan, which is a type of second-degree heart block, and junctional rhythms. On the right here, I've included some ECG strips of different types of heart blocks. And if you look at the first one, this is a first-degree heart block. So you have a constant PR interval throughout, and the other ones are the different types, which you can go through in your own time. Okay, so moving on to second-degree heart block. So the first type is Mobitz 1, also known as Wenckebach. It's defined as a progressively prolonging PR interval. So the PR interval keeps getting longer and longer and longer until it finally drops, and then the pattern repeats itself. Again, causes are increased vagal tone, certain drugs like beta blockers and calcium channel blockers, inferior MI, myocarditis, etc. And this is, again, something we're not too concerned about. It's quite benign, and we'll only treat the patients if they're hemodynamically compromised. Okay, Mobitz type 2, this is a little bit more concerning and something we should take more seriously if we ever see it. So in this case, the PR interval is constant, doesn't change, but often the P wave isn't followed by a QRS complex. So you have loads of missing heartbeats. And this is super dangerous because it can actually precipitate into a complete heart block. It can present with symptoms such as dizziness, syncope, cardiac death, and severe bradycardia. So the way that we manage this is with cardiac monitoring. So we're going to monitor the heart continuously. Temporary pacing, and then a permanent pacemaker as well. Okay, so this ECG strip, actually, let me go back. Yep, so these are just some ECG strips, and I've described them on the left. So yeah, here we have a second-degree AV block. So we can see that the PR interval across, let's just look at lead 2, it's constant throughout. So we can say that this is Mobitz type 1. And by 2 to 1 degree block, we mean that for every QRS complex, there are 2 P waves that are preceding it, meaning that you need 2 P waves for the impulse to be conducted to the QRS complex. So this patient will be experiencing some bradycardia. So whenever a patient is having symptomatic bradycardia, we're going to give them IV atropine 500 micrograms, and we keep giving this up to 3 milligrams if they don't improve. If this measure doesn't result in any response, we're going to try transcutaneous pacing, which is a temporary way of pacing the heart and increasing the heart rate, and it basically just stabilizes the patient until we can initiate a more permanent means of pacing. And we can also give isoprenaline or adrenaline infusion. Again, if there's no response, then we're going to move on to transvenous pacing, which is where we place a temporary electrode catheter into the right ventricle and apply an electrical stimulus. So we directly stimulate the right ventricle in order to get the heart pumping. Okay. Finally, we have third-degree heart block, which is the most dangerous of them all. And this is where there is a complete disconnection between the atria and the ventricles. So absolutely no impulses are conducted via the AVN. The waves that you do see on the QRS complex, on the ECG strips, the P waves and the QRS complexes, they appear independently of each other and aren't related to each other. So you won't see a sort of discernible pattern between the two. And so you might be wondering, well, if there's no electrical activity being conducted, how on earth do we still get a heartbeat? Well, that's because of these escape rhythms that come about spontaneously from the ventricle. So depending on where they come about in the ventricle, we're going to get narrow QRS complexes or broad QRS complexes. So if these spontaneous escape rhythms originate from the His bundle, you're going to get a narrow QRS complex at a rate of 50 to 60 beats per minute. So if we give them IV atropine, it might resolve the issue, especially if this problem is transient. But sometimes they may need permanent pacing. And if these escape rhythms originate from the His-Purkinje system, then that means that it's kind of originating more distally. So if you look at this diagram here, more around this area. So these don't yield very narrow QRS complexes. They're more broad, and so patients will be a lot more unstable, maybe experiencing dizziness and blackouts. So in this case, you're going to need a permanent pacemaker. I would recommend that you guys go through pacing, so temporary pacing, permanent pacing, and also ICDs. It can be quite confusing if you don't get the definitions right. So in your own time, try and do that. Okay, so moving on to arrhythmias. This is quite a heavy topic and can be quite confusing. So I've tried to create a diagram that will simplify things, hopefully. If you have any questions, just pop them in the chat. So arrhythmias can be divided into 2 types. They can be tachyarrhythmias or bradyarrhythmias. The latter I'm not going to be going through because they should teach this in the acute rotation. So I'm going to be focusing on tachyarrhythmias. So both, they're subdivided into further categories, but essentially what unites them all is the fact that the heart rate is always above 100. So they can be either narrow complex or broad complex. With narrow complex, the QRS complex is narrow, basically less than 120 milliseconds. And all narrow complex tachycardias are supraventricular in origin, meaning that the impulses meaning that the ventricular contractions, the origin of those contractions is from the atria. So it's the atria that are releasing these impulses, and those are eventually causing the ventricles to contract. So yeah, as I said here, ventricles depolarize via the normal conduction pathways, whereas in broad QRS complexes, the ventricular contractions are a result of impulses that originate from the ventricle itself. Or it might be due to defects in the conduction of impulses from the atria. So, okay, there are different types of narrow complex tachycardias. So you've got sinus tachycardia, AFib, atrial flutter, and a few others. The ones highlighted in red are what I'll be going through. There are a few of them, but I wouldn't get too bogged down by it. Just learn the general management, which is similar for all of them. Atrial fib and atrial flutter are a little bit different, but the rest are pretty much the same. And then ventricular fibrillation, ventricular tachycardia, bundle branch blocks, and antidromic AVRT are all broad complex. I'll be defining these orthodromic and antidromic AVRT in just a moment. One really important thing to note is that any type of narrow complex tachycardia that occurs in combination with a bundle branch block is going to lead to a broad complex tachycardia, even though it's narrow complex in origin, because it's in combination with a bundle branch block, which is a defect in the His or Purkinje system. It's going to cause a broad complex tachycardia. Okay, so here are just a few definitions of the different types of narrow complex tachycardias. So all the ones I've listed here. Wait, how do I get rid of this? Okay, sorry guys, I think that was on the screen the entire time. Okay, so narrow complex tachycardias. These are all, and the ones I've listed here are all regular rhythm. So the QRS complexes will occur in a regular pattern, but these ones are going to be irregular. So AV, torsade de pointes, and VF. So sinus tachycardia is literally a normal heart rate, a normal heart rhythm, but it's just occurring at a higher frequency than normal, and causes include anemia, infection, etc. Also, yeah, anxiety is a big one. Focal atrial tachycardia. So we know that the natural pacemaker of the heart is the SAN, but in this condition, other atrial cells act as the pacemaker and they outpace the SAN. And we'll be able to recognize this on the ECG because the P wave morphology will be a bit different. And atrial flutter, this is where electrical activity encircles the atria 300 times. So we're going to see this distinct sawtooth baseline. I'll be going through that in just a minute. And yeah, I won't talk about this right now because I'm going to be talking about it in a few slides' time. Okay, so AVRT, this is where there's an accessory pathway that connects the atria and ventricles. So in the normal anatomy, it's only the AVN that connects the atria and ventricles, but in AVRT, there's an accessory additional pathway, and that can cause narrow complex tachycardia. Well, depending on the rotation of the electrical activity. So yeah, as I said in the previous slide, and orthodromic, antidromic, I'm going to be going through that in a bit. And then you have AVNRT, nodal reentry tachycardia, which is where a circuit forms within the AVN. So you've got electrical activity in the AVN. Some of it goes into the ventricles, but some of it goes back into the atria. And yeah. Junctional tachycardia is where the cells in the atrioventricular node, they become pacemakers instead of the SAN, and this also gives narrow complex tachycardias. Okay, so this is just a really nice summary of the management of narrow complex tachycardias. So the first thing that you always do is stabilize the patient as much as you can. So if the patient's hypoxic, give them oxygen, attach them to some IV leads, and hook them to a 12-lead ECG so that you can continuously monitor their heart rhythm. Then assess whether they have any of these following 4 life-threatening features. So shock, chest pain, heart failure, syncope. These would suggest that the patient is hemodynamically unstable. So if these features are present, then you're going to immediately seek some senior help. You're going to sedate them and give up to 3 synchronized DC shocks to basically force the heart back into a normal rhythm. If that's unsuccessful, give them 300 milligrams of IV amiodarone over 10 to 20 minutes. And if needed, you can repeat the synchronized DC shock. Okay. If these life-threatening features aren't present, then the patient is sort of hemodynamically stable. So you establish whether they have a regular heart rhythm or an irregular. If it's not regular, then it means that it's most likely AF, which I'm going to be going through in the next slide. But if it's a regular rhythm, you're going to start off by doing vagal maneuvers. So you can do the Valsalva or a carotid sinus massage. So a Valsalva is when you get patients to blow into an empty plastic syringe. That's going to cause a transient increase in intrathoracic pressure and basically, decrease the heart rate. Or you can give a carotid sinus massage. So these vagal maneuvers, they essentially block the AVN and reduce the heart rate. Now, if these measures are ineffective, you can give adenosine. So first 6 milligrams. If unsuccessful, give further 12 milligrams. If unsuccessful, another 18 milligrams. So adenosine is very rapid acting, and it's an important antiarrhythmic that we use in supraventricular tachycardias because it reduces the heart rate by blocking the AVN. If it's contraindicated, we give verapamil, for example, in asthmatics. And if this measure is ineffective, you carry on and you give verapamil or beta blocker. And if that's ineffective, then we're going to give some electric shocks up to 3 times, but make sure that you always sedate them beforehand. To prevent these episodes of supraventricular tachycardia, you can give beta blockers and also consider radiofrequency ablation. Okay, moving on to atrial fibrillation. So this is a really important condition that you really need to know inside out. It's defined by this chaotic electrical activity. So you have irregular atrial contraction, and that means that the signals aren't being conducted properly to the through the AV node. On an ECG, you're going to see an irregular rhythm. So that's a really important keyword. And the P waves will be absent. There'll be no discernible P waves, which you can see in this ECG right here. So it's narrow complex. There aren't any discernible. It just looks like a squiggly line. So essentially, because the ventricles aren't filling properly and they aren't contracting properly, it reduces the cardiac output. And that means that blood stays within the ventricles longer than it should, and that can lead to clot formation or embolus formation. And this can lead to strokes and loads of other complications. Atrial fibrillation is a really important condition that is quite common in the elderly. So it's really important to know how to manage it. We classify AF using the CAM classification. So it can be a random first detected episode, or there can be a recurrent episode. So if it's paroxysmal, it means that it terminates on its own within 24 hours. If it's persistent, then it means it's not self-terminating and it's lasting for more than 7 days. And permanent is when patients have essentially just chronic AF that isn't responding to treatment and sinus rhythm isn't achievable. Symptoms and signs. So symptoms will be what you would expect: palpitations, shortness of breath, because cardiac output isn't what it's supposed to be, and chest pain. Signs, major one is just an irregular pulse. Okay, so the way I like to think about AF management is consider the following 5 questions. First, establish if the patient's hemodynamically unstable. You don't want to do anything else before this because, I mean, if you do, the patient could die. So if the patient's unstable, just initiate the A2E protocol and get senior help. Give them 3 synchronized DC shocks and correct any electrolyte abnormalities. If this doesn't work, then give them IV amiodarone. So this is what I mentioned here, right here. It's the same thing. Second, if the patient's stable, then you're going to think about whether there's any reversible causes of the AF. If there are, you're going to deal with them first. So if there's an infection, deal with the antibiotics, rehydrate them, correct any electrolyte or endocrine abnormalities. And then if you've resolved those underlying causes and there's still symptoms of AF, or there aren't any reversible causes, then you consider whether to rate or rhythm control the patient. You're also going to consider whether they need long-term anticoagulation and whether they'd benefit from ablation. Okay, so management, this is a really good summary slide for the different types of AF and how we manage them. So with paroxysmal, you're going to use a pill in the pocket strategy. So give them flecainide or sotalol. They can use it every time they experience some AF, because it's not something that's, common for them or something they experience all the time. Then with persistent AF, so depending on depending on when the AF started and when they present, we're going to have different management strategies. If they present within 48 hours of symptom onset, then first line is rate control. So by rate control, we mean controlling the heart rate, slowing it down. And we can do this by giving them a beta blocker or a non-dihydropyridine calcium channel blocker, or digoxin. So digoxin is quite good for patients with coexisting heart failure. Yeah, so you can give one or two of these. If that doesn't work, then we can give them, we can initiate rhythm control. And this is done in one of two ways. So pharmacological cardioversion. First, let me explain what rhythm control is. So this is where you try to revert the heart back into sinus rhythm. So you can do this with drugs, or you can do it via electric shocks. So drugs include beta blockers, amiodarone, and flecainide. So amiodarone, remember that it's what you'd give if the patient's got coexisting heart failure, and flecainide if there isn't any underlying structural heart conditions. And then electrical cardioversion. So if you choose this, you're going to heparinize the patient and make sure to sedate them from beforehand. The reason we heparinize, because heparin is an anticoagulant. So when you electrically cardiovert patients, the moment you cardiovert them, then there are a higher risk of embolus formation. So you want to heparinize them to thin out the blood and reduce the risk of that happening. Okay, so if they present more than 48 hours after symptom onset, then if they're above 65 or have a history of ischemic heart disease, you're going to rate control. First line is beta blocker, non-hydropyridine calcium channel blocker, one of the two. Second line, you'd consider adding digoxin, and third line, consider amiodarone. If they're less than 65, if they're symptomatic, if it's their first presentation, if it's just lone AF, or if it's then you would rhythm control. And with rhythm control, in this case, where it's the patient presents 48 hours after the symptom onset, then we prefer electrical cardioversion over pharmacological cardioversion. There's two ways we can do this. We can either anticoagulate the patient for 3 weeks before the procedure. This is just to ensure that there are no clots that are in the heart or anywhere when we cardiovert. Or we can do a transesophageal echocardiogram to immediately exclude a thrombus, then heparinize them, sedate them, and then immediately cardiovert them. Okay, so for permanent AF, in this case, these patients have chronic AF. They can't be cardioverted, so you can't do rhythm control, essentially. All you're going to do is rate control and anticoagulation. With all three types of AF, you're always going to consider anticoagulation, which you're going to use the CHAD-VAS score to determine whether to give them anticoagulation or not. And so these are the factors, and you're going to get points whether the patient has them or not. So if the patient's got a score of 0, then it means they don't need any thromboprophylaxis. 1, it would be ideal to give it to them. And if it's 2 or more, then you should definitely give it to them. So you're always going to consider this, but you're going to measure the risk of clotting against the risk of bleeding. So for that, you're going to use the HAS-BLED classification, the HAS-BLED score. And if the patient's got a score of 0 to 2, they have a low risk of bleeding. If it's 3 or more, they've got a high risk. So you're basically going to weigh the risks versus the benefits. Post-electrical cardioversion, you're always going to give patients anticoagulants for at least 4 weeks. If they've got risk factors for ischemic stroke, you're also going to give them lifelong oral anticoagulation. For patients who've had catheter ablation, you're going to give them anticoagulants for 2 months if the CHAD-VAS score is 0. Otherwise, if it's like 1 or more, you're going to give them long-term anticoagulants. And the choice of anticoagulants, so in the acute setting, you're going to give them low molecular weight heparin. If they've been deemed to have a high embolus risk, give them a DOAC. And then in the long term, you can give them a choice between a DOAC or warfarin. So DOACs are direct oral anticoagulants. Okie dokes. Let's move on to atrial flutter. So as I defined before, atrial flutter is where you basically have this rapid atrial contraction. The electrical activity encircles the atria over around 300 times. And so you're going to see on the ECG this sawtooth appearance that's best seen in leads 2, 3, and AVF. So it's a super fast heartbeat, but it's regular. So as we said, the AVN is what conducts the impulses from the atria, but depending on the degree of heart block, so the AVN is not going to conduct every single impulse. The impulses that it does conduct will result in a heartbeat. So the underlying ventricular rate is going to be dependent on the degree of heart block, and that's going to be in factors of 300. For example, if it's a 2-to-1 heart block, then there's going to be a heart rate of 150. It could be 100, 75, etc. And one thing to note is that vagal maneuvers or adenosine can unmask flutter waves. So these, as I mentioned, vagal maneuvers and adenosine, they transiently block the AVN, so they slow down the heart rate enough to where you can see these flutter waves. In atrial flutter, we don't refer to P waves as P waves, we just call them F waves. And in this situation, these flutter waves will best be seen in V1. Okay, so management is, we're going to give them amiodarone to restore their sinus rhythm. Amiodarone is a really good antiarrhythmic to do that. The management is quite similar to AF, so you're going to rate and rhythm control them and anticoagulate for 3 weeks. And if rate control is proving difficult, give them IV amiodarone. So atrial flutter is actually not that sensitive to drugs. It's very sensitive to cardioversion. So when you do cardiovert them, you can start off by giving lower energy shocks. So you can start with 70 to 120 joules. The issue with atrial flutter is that it has a high recurrence rate. So even if you manage it one time, it can come back again. So the definitive curative option is radiofrequency ablation of the tricuspid valve. Here are just a few ECG traces. So you can see here that there are these flutter waves, and it's like the sawtooth pattern. So here you can see that there are 3 F waves for every QRS complex. So it's a 3-to-1 block, right? So of the 3 F waves, only 1 is conducted. So here the underlying heart rate will be 300 divided by 3, which is 100 beats per minute. Okay, here again, so you have the 2 P waves. The second one's merged into the QRS complex, but yeah, you have a 2-to-1 block, and QRS complex is pretty regular. This is regular as well. And here, so this is just an example of this, what I was talking about here. So you can see that this patient, they presented with tachycardia, and it was assumed to be AVRT or AVNRT. But when they were given adenosine, it slowed down the heart rate to the point where you could see these flutter waves. So that obviously changed the management. So AVRT, as I mentioned before, it's when you have this accessory pathway between the atria and the ventricles. And depending on how this electrical activity moves between this accessory pathway, we're going to get a different QRS morphology. So if it's orthodromic, it means that, so you can see here is where there's an accessory pathway. So usually electrical activity shouldn't be able to pass back into the ventricles like this. But here you have this antegrade conduction, antegrade meaning clockwise, right? So in this situation, you have a normal QRS complex. The reason why is because the electrical activity is moving down the bundle of His, leading to nice, short duration QRS complexes. However, if it's antidromic, which means that it's a anti-clockwise motion, so instead of electrical activity going out of the ventricles into the atria, they're going from the atria into the ventricles from this accessory pathway, then that is retrograde conduction, anti-clockwise. So in this situation, you're going to get a wide QRS complex with a delta wave. And this is what you see in Wolff, Parkinson, White syndrome. Okay, let's quickly do an SBA. So I'll give you guys a moment to read through it and we'll go through the answer. Okay, does anyone want to have a go at answering this question? Okay. If not, that's fine. In the interest of time, I'm going to move on. So you essentially have this elderly lady with AFib. She's come to hospital with a massive GI bleed, and she's hemodynamically unstable because she's got tachycardia and she's hypotensive. It has her, the stem contains her past medical history. She's on warfarin, and when you begin the A2E assessment, you ask for her INR to be checked, and it comes back as 6.5. So the INR is essentially a measure of how quickly your blood clots. So it should be around 1, but in patients with on warfarin, these targets might be a little bit different. But this means that the blood is taking very, very long to clot, and as a result, they can bleed. There's a risk of them bleeding out. So the question is asking, what do you do in this situation? Well, it's really important to remember that when a patient is undergoing any type of massive bleed, you're going to stop the warfarin immediately, regardless of what their INR is. You're going to give them IV vitamin K and prothrombin complex concentrate. This answer was wrong because here it says that you have to give it orally, but in major bleeds, you'd give them IV vitamin K. Here, so this, you'd follow this if the INR is above 8 and there's minor bleeding. This one would be the case, would be what you do if the INR is between 5 to 8 and there's minor bleeding. And the last one is when the INR is between 5 and 8 and there's no bleeding. Okay, here I've just pasted a table of what you should do in situations where there's bleeding and different INR values. So it'd be worth just going through this and memorizing it. Okay, next question. Gonna give you guys a moment to read through it. Okay, quickly gonna go through it. So essentially in this, with this patient, you suspect that one of her medications might have increased her INR levels, and then the answer is sertraline. So basically there are certain medications which inhibit or induce an enzyme system. So the cytochrome P450 enzyme system, it metabolizes certain drugs, and there are other drugs which induce or inhibit it, and it'd be worth going through them. So sertraline is one of those drugs which increase the potency of warfarin and basically lead to higher INRs. So other factors that increase the potency of warfarin include cranberry juice, NSAIDs, liver disease, and many more. Okay. So I hope all of that made sense. I'm now quickly just going to run through infective endocarditis and rheumatic fever. Okay, so infective endocarditis is where the endocardium of the heart is inflamed. So we know, and also the heart valve. So we know that the heart is composed of 3 layers. You've got the outermost layer, which is the epicardium, then you've got the myocardium, and then the innermost layer is the endocardium. And in this condition, it's the innermost layer that's affected, and it's a disease that is quite systemic. So you're not just going to have symptoms involving strictly the heart, but other parts of the body. So essentially what happens is that you get this transient bacteremia. So I've got the pathophysiology here, and this leads to, when it gets to the heart, it can cause damage to the valves, and then colonies of bacteria will grow on the valves, forming vegetations, and this will be visible macroscopically. This is going to lead to regurgitation and worsening heart failure because the valves are dysfunctioning. So it's really important to remember this golden rule that anytime a patient presents with fever and a new murmur that wasn't present before, then it's IE until proven otherwise. So risk factors, there are loads of risk factors, and you can check out the Oxford Handbook for a full list, but the strongest one is a previous episode of infective endocarditis, bacteremia, so various procedures, IV drug users, they're also at higher risk, and patients who have a pre-existing valvular lesion, so whether they be congenital or acquired. Causes, there are many. So Staph aureus is the most common, and then there are a number of different kind of situations where there are other organisms that would be more likely. For example, patients that are less than 2 months post-valve surgery, it's more likely for the organism to be Staph epidermidis. If they've got poor dental hygiene, then it's strep viridans. This is a kind of weird one, but strep bovis is associated with colorectal cancer. There are also some non-infective causes such as SLE and malignancy, and some culture negative causes where essentially the patient's got signs of infective endocarditis, but no organism can be cultured. So causes of this include prior antibiotic therapy, HACEC organisms, Coxiella, Bartonella, Legionella, Chlamydia, etc. So this table just goes through some of the signs and symptoms. So you'll have systemic features of fevers, rigors, myalgia, arthralgia, and then there'll also be a murmur. Immunological phenomena, so splinter hemorrhages, Osler's nodes, Janeway lesions, Roth spots. I just wanted to point out that Osler's nodes and Janeway lesions, sometimes people find it difficult to differentiate between the two. So the way I like to remember is that Osler's nodes, like Osler's owl, like they're quite painful and they're raised nodules, whereas Janeway lesions are macules, meaning they're flat and they're painless. Roth spots are basically just retinal hemorrhages. You can also get petechiae, which are just subcutaneous hemorrhages, and hematuria, which occurs secondary to glomerulonephritis, where the infective endocarditis includes the renal system as well. Embolism can form because, remember, the heart valves are not functioning properly, so blood is, there's regurgitation, and that can increase the risk of embolus formation. So all of these are the different features. So the way that we diagnose it is using the modified Duke's criteria, where infective endocarditis is diagnosed if pathological criteria are positive, or there are 2 major criteria, or 1 major and 3 minor criteria, or 5 minor criteria. So by positive blood cultures or pathological criteria, we mean that we can essentially culture the organisms. So if you can culture 2 organisms, and they're the typical organisms such as strep viridans or any of the HACEC group, then you've confirmed the patient has infective endocarditis. If the patient's got persistent bacteremia from more than 2 cultures taken more than 12 hours apart, or 3 positive blood cultures from less specific pathogens, so Staph aureus and Staph epidermis, that's also another factor that confirms IE. And also if there's positive serology for any of these species, so Coxiella, Bartonella, Chlamydia. Another major criteria is the presence of endocardial involvement. So if the echocardiogram shows valvular regurgitation or any kind of abscesses, then that's indicative of infective endocarditis, or if there's any indication of abnormal activity around a prosthetic valve. Minor criteria, so if the patient's got a predisposing heart condition or they're an IV drug user, if there's any microbiological evidence that doesn't meet the major criteria, if they've got a fever, vascular phenomena, which I mentioned in the other slide, or immunological phenomena. And here are just a few pictures of these. So splinter hemorrhages, you get these kind of lines on the nails, Janeway lesions, so they're these flat, painless macules, Roth spots, so retinal hemorrhages, infarcts from embolism. And the way we manage them depends on whether the valve that's affected is native or prosthetic. Native meaning the normal heart that a patient has, biological, and prosthetic is just the valve that's been surgically inserted. So initially you would go with some blind therapy. So native, if it's a native valve, give them IV amoxicillin, and you can consider adding some low-dose gentamicin. If it's prosthetic, give them some vanc and rifampicin and also low-dose gentamicin. And then here, so depending on what the organism is that's cultured, you're going to have different management protocols. So with streptococci, it doesn't matter whether it's a native or prosthetic valve, you're always going to give benpen. But if the streptococci are less sensitive, you can add in some low-dose gentamicin. With staphylococci, native valves, you'd give flucloxacillin, and if it's prosthetic, you're going to add rifampicin and low-dose gentamicin. So you can see that with the prosthetic valves, you add more antibiotics. And if the patient's penicillin allergic, if they've got MRSA or severe sepsis, you're going to give vancomycin and low-dose gentamicin. Surgical indications. So sometimes drugs will not resolve the problem. So then you have to do surgery. And indications for surgery include if the valve is completely dysfunctional, if there's resistant infection, if after antibiotics you still get recurrent emboli, if there's cardiac failure that's resistant to drug management, and if there's an aortic abscess. One thing to note, and this is something that they love to ask about in SBAs, is about prophylaxis in infective endocarditis. So in 2008, NICE basically said that there's no need to give prophylaxis to these patients. However, if they're going through kind of a procedure, if they're going through a if they basically have an infection for which they need antibiotics, so if they've got like a GU infection and they're being given antibiotics already, then you can just add in antibiotics that cover for infective endocarditis organisms. Okay, just last section. So rheumatic fever. Rheumatic fever is quite rare in the developed world, but it's essentially a condition that develops a couple of weeks after a strep pyogenes infection. And what happens is that the strep pyogenes cell wall contains M protein. And what happens is that when antibodies develop to M protein, they can cross-react with myosin and arterial smooth muscle. And this is thought to be mediated by molecular mimicry. Here are some. So you can see that with rheumatic fever, because it affects the valves, you can get severe mitral stenosis. It almost always affects the left-sided heart valves and can cause permanent damage. And one thing to note is that it's the most common cause of mitral stenosis. So here are just some features of rheumatic fever. So physically, you'll be able to see erythema marginatum, which is this pink macular non-itchy rash. Macular meaning flat, and it's non-itchy. And then ash of body. So if you take a histological sample of the myocardium, you're going to see these granulomatous nodules. This is pathogenomic for the disease, but it's quite rare to see. And the way that you diagnose and manage it. So we use the revised Jones criteria. So there has to be evidence of a recent strep infection, plus 2 major criteria, or 1 major and 2 minor criteria. So evidence of a recent infection include a positive throat culture, if a rapid antigen test comes positive, if there's recent scarlet fever, etc. Major criteria, so there's the Jones acronym, so joint pain, carditis, nodules, so these are subcutaneous painless nodules. If they have them, then that's the major criteria, erythema marginatum, and Sydenham's chorea, which is basically this kind of like uncontrollable movement of the limbs. Minor criteria, you can use the CAFE-PAL acronym. So CRP is raised, arthralgia, so fever, ESR is raised, prolonged PR interval in the ECG, basically signs of a rheumatic infection and leukocytosis. The way that you're going to manage it is by recommending bed rest for the patient for at least 2 weeks, and until the CRP is normal for at least 2 weeks. You're going to give them immediate IV benpen and and then oral penicillin for 10 days. For analgesia, you're going to give NSAIDs as first line. So this is if the patient's experiencing carditis and arthritis. If the patient has moderate to severe carditis, such as cardiomegaly, then you can also add oral prednisolone. And if they're experiencing Sydenham's chorea, you can give haloperidol or diazepam. So that was essentially a quick run through our different arrhythmias, infective endocarditis, and rheumatic fever. I hope that helps. Sorry, it was a bit speedy. I just wanted to be conscious of the time. This is a feedback form. If you wanted to give some feedback, we'd really appreciate it. I'm now going to just hand over to Ameerah. Just gonna.
All right. Okay. Hi guys. So thank you so much for staying with us. What I'll try to do is finish by about 8:30, but if you need to leave earlier, feel free to do so. So just let me know if you can see this. Hey guys, can you see this?
Yeah.
Okay, great. So what I'll do is cover valvular disease and some murmurs, and then we'll move on to myocardial and pericardial disease, and aim to finish by 8:30. So Right, very quick overview. Valvular disease can present as murmurs on auscultation, thrills on palpation. Just a note, there are many different hints as to whether someone has valvular disease that you can pick up even before you get to the heart. So peripherally, your pulses, it may be a slow rising pulse, maybe something that's quite difficult to feel in the first place. You may notice a malar rash, changes to the carotids even. And so with all of these different changes, there are loads of different hints with the cardiac exam. It's also important, and I think it looks great in OSCE, to think about what might be causing the valvular disease. So you may pick up signs such as for infective endocarditis, also known as Janeway lesions, although these are quite rare. And you may also pick up sort of consequences of the valvular disease. So if someone has heart failure, for example, you may see peripheral edema and the different signs and symptoms that Sumayyah mentioned earlier. So importantly, not all murmurs are actually pathological. In fact, there are a few benign murmurs, which are completely physiological. They can happen in what's known as a hyperdynamic flow state, and this is a condition in which there is sort of an increased circulatory volume, like in pregnancy or anemia. In anemia, for example, there's a reduction in red blood cells, so the blood is a bit less viscous than normal, so more prone to be more turbulent, and these murmurs tend to be a bit more shorter, systolic. They're sometimes also postural. And what you'll see mentioned throughout these slides is the echocardiogram, and this is just the gold standard for most diagnoses. And severity is also quite important to assess, just because that helps to guide management. So if someone has very severe disease, you would want to opt for more invasive management with surgical operation, whereas if someone has less severe disease, you would go for less invasive, more symptomatic management. And these are just a few parameters that you might be considering. So as I mentioned, less invasive versus more invasive management. Surgical should ideally be done before any irreversible ventricular dysfunction occurs or pulmonary hypertension for better outcomes. And when it comes to sort of surgical treatment, you would want to opt whichever valve, if you're doing a valve replacement, you would opt for, depends on the sort of patient, and it would be decided on a case-by-case basis. But generally speaking, they're mechanical versus bioprosthetic valves. Mechanical valves, you need lifelong anticoagulation, whereas bioprosthetic, you don't necessarily. And so usually you would prefer mechanical valves in someone who is younger. They also take a longer time to fail, so about 15 to 20 years before someone needs a revision operation, whereas bioprosthetic valves take about 10 years before someone needs a revision operation. So usually you would prefer mechanical in someone who's younger, bioprosthetic in someone who's older, maybe has a lot more comorbidities, high risk of falls, so loads of different things where you won't necessarily want to start them on lifelong anticoagulation. And this is just a useful tip to remember maybe for OSCEs, but this is the scale from 1 to 6, which you can use to grade murmurs. So it runs basically in OSCEs, usually it's about grade 3 or 4, where you can actually hear the murmur, and either there's no palpable thrill, so that's grade 3, or there is a palpable thrill, which is grade 4. And grade 6 is where you can actually hear the murmur without even listening or auscultating, but that's quite rare. Okay, so this is a fantastic video by Zero to Finals. I would really recommend looking into it, but I just wanted to give you this diagram to have a look at where exactly we're listening. So for the purposes of this talk, I'll be focusing on the mitral and aortic areas. And if you just, for the mitral area in any case, this is actually not really where the valve is, it's at the apex, but that's just where you can hear it loudest. And this is a useful, these are two mnemonics, which can be useful. So RILE is where your right-sided murmurs are louder on inspiration, whereas your left-sided murmurs are louder on expiration. And then there's also ASMR, which is a mnemonic for systolic murmurs, so aortic stenosis and mitral regurgitation. So that's just a very quick, I would really recommend looking into this video. It explains it very clearly, but for the sake of time, I'll move on. So with aortic stenosis, firstly, this is broadly, if you think about it in terms of the narrowing of the aortic valve. So the aortic valve is the one that sits between your left ventricle and aorta. Mostly it's due to age-related degeneration or maybe calcification of the valve. But if you have someone who's a bit young, you might want to think about congenital bicuspid valves. So normally it's tricuspid, but in some it can be bicuspid, and that can predispose them to developing aortic stenosis. Now, the actual pathophysiology is where the aortic stenosis actually is obstructing the emptying of the left ventricle, and this in turn kind of increases the pressure in the left ventricle because it's now having to work much harder in order to expel that blood into the aorta. And so the heart tries to adapt and remodel, and what it does is hypertrophy. So you end up with what's known as concentric hypertrophy in order to increase the contractile power of the heart. In terms of what you would actually see, in terms of presentation. There's usually what's known as a SAD triad. These are quite general symptoms, and you would ask in any kind of cardiac history. So it's not necessarily possible to differentiate between different types of valvular disease on this basis alone, but in SBA stems can be useful. So syncope, angina, and dyspnea, and it's typically exacerbated by exertion because the demand on the body is increasing in these sorts of states. So the reason why you kind of get syncope is because you're getting less blood flow to the brain, angina because there's less flow in the coronaries, and dyspnea usually is secondary to the heart failure that develops as a result of aortic stenosis. And generally speaking, people can be asymptomatic even if they have aortic stenosis. So it kind of becomes symptomatic as the disease severity increases. And so there are some ways to quantify this on echocardiogram. So you can look at valve area, you can look at pressure gradient. Valve area normally is about 3 to 4 centimeters squared, but in aortic stenosis, particularly severe aortic cases, that would be less than 1. Whereas pressure gradient, so the pressure at the aorta versus that in the left ventricle, can exceed over 40 millimeters of mercury, when in normal sort of cases, that would be just a few millimeters of mercury. So on examination, starting peripherally, usually you have this sort of hard to feel pulse. And that's also known as a low volume pulse. And it literally is because the volume of blood is so low, you can't really feel it in the peripheries. And it's also slow rising or anacrotic. And you can really only tell if something's slow rising if you have an arterial line in, where you can actually see the peak of the pulse is a bit later than you'd expect. But with time and experience, it is something that can be picked up on examination. You also have a narrow pulse pressure. So pulse pressure is an important concept to get to sort of get acquainted with, and it just refers to the difference between the systolic and diastolic pressure. And the reason why it's narrow in aortic stenosis is because you have a reduced stroke volume. So there's less blood actually being ejected from the heart in the first place, so your systolic blood pressure decreases, and as a result, the difference between the systolic and diastolic is lower, and so you have a narrower pulse pressure. There's also a classically sort of obvious apex beat. It's termed heaving, so that's a buzzword used in SBA stems sometimes, and that's because of pressure overload. So basically, the heart is having to work faster. Apex beat is basically sort of you're kind of trying to look at how the systolic component of the systolic-diastolic cycle. And then finally, when it comes to the murmurs, this is a very, very important buzzword, the ejection systolic murmur. So what you're looking for is a sound between the lub and the dub. And importantly, it kind of increases. So the pitch goes up and then it goes down. So it's a bit different to things like mitral regurgitation, where the intensity tends to stay the same throughout. It's also quite early on in the sort of sound. And that's because the aorta is sort of that's the point at which the valve is moving. In terms of the actual sound, so I'd just like to bring your attention to S2. So S1 is the first heart sound, S2 is the second. S2 refers to the closure of the aortic and the pulmonary valves. And what can happen in very severe aortic stenosis is that you have a loss of S2, and that is very, very, that indicates quite severe or critical aortic stenosis and would warrant surgery. And this tends to occur because the aortic valve is just not able to basically, it's not able to close as much because you have very thick immobile valve leaflets, and so the sound becomes progressively quieter, such that it ends up being fairly delayed following P2 even. Moving on, these are some videos of heart sounds. There are YouTube videos throughout this that I would highly recommend you look into, and just have a listen, get acquainted with what the different sounds sound like, and this should hopefully get better with time as well. I just want to bring your attention to different investigations. So usually on chest X-ray, you can see a prominent dilated ascending aorta. Sorry, not usually, but it is possible to see this. And this aortic dilatation can happen for many different reasons, but in this case is usually due to different sort of altered blood flow dynamics because of the valve dysfunction. ECG, you will see signs of left ventricular hypertrophy. I'm not going to go into too much detail on what these are, but you can look up the Sokolov-Lyon criteria, which very specifically quantifies what you should see. P. mitrale may also be present if severe enough. So that's where you have left atrial enlargement, and that's sort of the ECG, the corresponding ECG trace for that. And left axis deviation can also kind of accompany left ventricular hypertrophy. And finally, echo is diagnostic, and what you'd see is a narrowed and immobile calcified aortic valve. And then management, if someone is asymptomatic, then you're likely going to observe and monitor over time. Or however, if someone is symptomatic, or if they're asymptomatic but the valvular gradient is over 40 millimeters of mercury, and maybe if they have features of left ventricular systolic dysfunction, you may consider aortic valve replacement as well. If someone is not fit for surgery, then you would want to consider a TAVI. So this is a transcatheter aortic valve implantation. And this is where a catheter is inserted via the femorals or an artery in the chest into the aorta to place a new sort of valve over the aorta. And prior to surgery, what is often done is cardiac catheterization. And this is where, so someone, if they have chronic aortic sort of stenosis, you may have coronary angiography to assess if there's concomitant coronary artery disease. And so in that way, you can consider doing a bypass at the same time as this aortic valve replacement. So you kind of are reducing how many times you have to operate. And then finally, aortic sclerosis is a sort of valvular problem that presents very similarly to aortic stenosis, but this is where you have calcification and thickening of the valve without a obstruction of the ventricular outflow. So it's a bit different to aortic stenosis. So what you'll see or hear or pick up is an ejection systolic murmur, but there won't be necessarily carotid radiation. The pulse might be normal, S2 might be fine, and there won't necessarily be ECG changes either. Okay, so that's a very quick overview of aortic stenosis. So just I'm going to move on to aortic regurgitation now. And this is where someone develops sort of an incompetent aortic valve. And so what's supposed to happen is the aortic valve is supposed to close. And when the aortic valve closes, no blood should be allowed back into the ventricle. And so in this case, that is not happening. So you have blood that's going back from the aorta into the left ventricle during diastole. And it can be due to, it can be acute, but it can also be chronic. So here are a few causes for the above, mix of both acute and chronic, and you can think of it in terms of infective, connective tissue diseases, rheumatology, and then just a miscellaneous range. Another way to think about it is thinking about where exactly the problem is, as well as whether it's acute or chronic. So aortic regurgitation can be due to a problem in the valve leaflets or the aortic root. If it's in the valve leaflets, you're thinking along things about sort of rheumatic heart disease, infective endocarditis, congenital and degenerative disease, whereas with aortic root disease, it's more along the lines of aortic dissection, connective tissue diseases, and aortitis. And then if you're thinking acute and chronic, you'd be thinking about things like infective endocarditis, rheumatic fever, aortic dissection, and then chronic things would be so arthritides, bicuspid valve, connective tissue disorders, and the list goes on. So in terms of history and exam, history, the symptoms are very similar to aortic stenosis and even heart failure. And indeed, if it is very severe, it can lead to left-sided heart failure, which would present as Sumayyah sort of mentioned earlier on. And then on exam, there are a few characteristic signs and symptoms that to pick up. So in particular, there's a wide pulse pressure this time as opposed to narrow. And this is because of two reasons. So you have one, a higher systolic, and two, a lower diastolic. So pulse pressure is the difference between the two. And so the reason you have a reduction in the diastolic is because all that blood during diastole is going from the aorta into the left ventricle, whilst the systolic is increased because all that blood that's now come into the left ventricle is now being expelled during systole, which then increases your systolic pressure. And the heart does that in order to maintain that forward cardiac output. There's also an early diastolic murmur that can be increased by the hand grip maneuver, and this is because the hand grip maneuver increases afterload, so that's the amount of pressure that the heart needs to exert to actually eject blood during the ventricular contraction. And so because the afterload is now increased, that also means that the regurgitant blood flow is also increased. And finally, you can also get a mid-diastolic murmur in severe aortic regurgitation. This is known as an Austin Flint murmur, and this is sort of a low-pitched rumbling murmur that's best heard at the apex, particularly on leaning forward and whilst expiring. Now, importantly, this doesn't always have to be a mid-diastolic murmur. It can also be pre-systolic, and it's thought to be actually due to the heavy jet of blood that's kind of moving during aortic regurgitation, affecting the mitral valve. I'm not going to go into too much detail on this today for the sake of time, but it's worth reading up on. And finally, the apex beat in this case is going to be thrusting and displaced laterally, and this occurs because you have much more blood in the actual ventricle. And so just a quick way to think about it. So it's a bit different to the hypertrophy which occurs in aortic stenosis. Here you actually have eccentric hypertrophy, and that's because the heart is trying to increase how much blood it's actually able to carry. So it tends to dilate as a result. And then this is, again, just another way to show the widened pulse pressure that happens as a result of the regurgitation. And then this is a useful YouTube video just to hear what it actually sounds like. And just to quickly point out, the wide pulse pressure, you can also hear a sort of water hammer pulse. And this is because there's a rapid upstroke and then a rapid downstroke. So the rapid upstroke is because there's a very sudden increase in the systolic blood pressure because you have a greater stroke volume. Whereas the rapid downstroke is because there's a sudden fall in diastolic pressure in the aorta. And so I'm just going to quickly move on to the actual investigations and management. So there are loads of different eponymous signs, even more than those that are listed here. But generally speaking, all of these are secondary to that widened pulse pressure. So here I'm going to let you have a read of the slides later on. But the investigations are very similar to aortic stenosis and indeed other types of valvular disease, where you have a chest X-ray, again showing sort of dilatation of the ascending aorta. You may have signs of heart failure, so remember the A2E. ECG may show signs of left ventricular hypertrophy. An echo may show signs of a dilated left ventricle, aortic root enlargement. And then the management would be sort of involving treating the underlying cause. So if it was due to rheumatic fever, for example, you'd want to treat that. If it's asymptomatic or mild, you would want to consider observing. But if someone is symptomatic, then you can try to reduce afterload with vasodilators, diuretics, consider reducing systolic blood pressure with ACE inhibitors. For hypertension management, you would want to treat any subsequent heart failure or concomitant heart failure and consider echo monitoring every 6 months. If it's very severe, you'd opt for valve replacement. So all in all, very similar to aortic stenosis. Now, mitral stenosis is very similar to aortic stenosis. It's just happening in the mitral valve. So this is a valve between the left atrium and the left ventricle. And here you have sort of thickening and immobility of the valve, which then leads to progressive narrowing. So there's less area through which the blood can actually flow down into the left ventricle. And this then results in the left atrium enlarging and increasing pressure. And so what can then happen is that there's a back pressure of blood into the pulmonary system, resulting in pulmonary congestion and hypertension, and that in turn can lead to right-sided heart dysfunction and failure. Importantly, a very common association tested in exams is atrial fibrillation, and this is because there's an increase in the left atrial pressure, which increases your risk of systemic emboli. So strokes, for example, are very common in mitral stenosis. And then on examination, there are a few characteristic signs and symptoms. So malar flush refers to a plum red discoloration of the cheeks, and this is usually due to the back pressure of blood into the pulmonary system. And then this causes carbon dioxide retention, which can then cause a dilation of the cutaneous vessels. Importantly, you can get malar flush with peripheral or central cyanosis. It is possible for both to occur at the same time. And then the other sort of signs you can pick up and you can determine based on whether the mitral valve is kind of opening or closing. So when the mitral valve is stenosed and it's trying to open, the snap occurs because there's a very abrupt downward movement of the valve leaflets into the left ventricle, because as soon as that left ventricular pressure drops below the left atrial pressure, this very thickened, immobile stenosed valve is sort of not very compliant, so it very quickly sort of snaps onto the left ventricle. And the murmur, so then there's a subsequent immediate rumbling low-pitched murmur that happens after that snap, and that's just because the blood is now flowing passively from the left atrium into the left ventricle through the stenosed mitral valve, resulting in turbulence. And you can also, so it is decrescendo crescendo. So it's decrescendo because that blood is flowing initially passively down from the left atrium into the left ventricle, but then the crescendo occurs when there's active sort of atrial contraction, increasing how turbulent the flow is and thereby increasing the volume of that murmur. And then when the mitral valve attempts to close, these mobile but very stiff leaflets produce this loud S1 sound. And it's generally because the high left atrial pressure has kept those leaflets relatively wide apart during diastole. So when they then have to close, they then have to move through a much larger sort of plane in order to fully close. And so that movement results in a louder S1 sound. And then on the other hand, the apex beat in itself is sort of a product of systole, as mentioned earlier. But because there's now a very abrupt, forceful closure of that mitral valve, that results in a tapping sound. So the more severe the stenosis, the longer the murmur is going to be, and the closer that opening snap will be to S2. And on ECG, you can also see what's known as a bifid P valve, and that's secondary to the left atrial enlargement, which happens in response to the stenosed mitral valve. These are a few signs and symptoms you may see in the history. There is also what can happen is a left atrial enlargement mass effect, so that can affect the recurrent laryngeal nerve, the esophagus, and bronchi, resulting in their respective symptoms. Again, here's another YouTube video which you can review, which just shows what it actually sounds like. And then investigations-wise, on chest X-ray, you can see signs of an enlarged left atrium, signs of heart failure, pulmonary hypertension. ECG will demonstrate potentially atrial fibrillation, but also that P mitrale pattern in the previous slide. And then the echo, depending on how severe it is, you'll see a reduction in the valve area. So in this case, less than 1 centimeter squared is severe, and then less than 2 is about pretty moderate. And then management, again, very similar to before. If it's very mild, you can observe, treat any heart failure, and also consider anticoagulation if someone has atrial fibrillation. And you'd also, if it's very severe, you could look into more interventional options such as percutaneous commiserotomy, open valvotomy, and mitral replacement. Okay, so this is a chest X-ray. So this is someone who has sort of mitral stenosis. They've had a sternotomy, and they also have a prosthetic mitral valve. And I just wanted to bring your attention to the fact that there are sort of two kind of borders. So the more medial line is this enlarged left atrium, so it's huge, and the heart border is more lateral, so this is a blue dotted line. So this is on PassMed, so I definitely encourage you to have a look there for more detail. I'm just going to move on now to mitral regurgitation. So in this case, this is very similar to aortic regurgitation. In this case, you just have a leaky mitral valve. So there are loads of different causes, mitral valve prolapse, which I'll come on to in a moment. Yes, I can see a hand up.
Hi, yeah, sorry, I just wanted to quickly say, I think I'm the last one left and I do have to go now. So I don't want you to keep talking when no one's here anymore. I'm not sure, there might be, because I think everyone else are presenters as well, right?
Yeah, that's absolutely fine. Feel free to leave. I think this is being recorded, so we can definitely have it on the YouTube channel. Thanks so much for joining.
Thank you so much. Sorry for having to leave.
No worries. Thanks so much.
It's helpful though. Thank you.
No worries. Okay. So I'll just continue for people who are watching online. So basically, leaky mitral valve. As I mentioned, prolapsed mitral valve is the most common cause in the developed world, but rheumatic disease in the developing. And it's the same sort of principle where you have a reflux of blood from the left ventricle to the left atrium during systole, and then over time you have an increased left atrial pressure, as well as left ventricular and diastolic pressure, and then you can have symptoms of heart failure if it progresses untreated. And it's associated with polycystic kidney disease and collagen disorders. And then on examination, you'll see characteristic sort of buzzwords here, but there's a pansystolic blowing murmur, and the reason why it's systolic is because in, so pansystolic blowing murmur, it's best heard at the apex and radiates into the axilla. S1 might be quiet, and this is just because the mitral valve is not closing fully. And severe mitral regurgitation can actually cause a split of the S2, and this is because physiologically, as mentioned earlier, S2 is kind of divided into the aortic valve closing first and then the pulmonary. And so this is seen in the majority of patients just normally. But what can happen is in mitral regurgitation, there's actually early closure of the aortic valve, and so there's increased splitting that's fixed. And so this early closure of the aortic valve is actually because more of that left ventricular volume enters the left atrium, and so the left ventricular pressure has to reduce much quicker, and so it's lower than the aortic pressure earlier, and so the aortic valve is then going to close earlier than expected relative to the pulmonary. The third heart sound, or S3, is sort of a rare extra heart sound that often occurs, that soon occurs after the normal two lub-dub sounds, and this is commonly associated with heart failure, and it's due to blood actually rushing very rapidly from the atrium into the ventricle in early diastole. And then in this case, the apex beat is displaced laterally with a diffuse thrusting character, and basically in more severe disease, the larger the ventricles are going to be, and this will then therefore sort of exacerbate how prominent the apex beat is. Investigations, again, very similar to before, left atrial enlargement, P mitrale, AF on ECG, and then on echo you may see a dilated left atrium and ventricle. And then management, you'd be looking at acute medical management, such as nitrates, diuretics, positive inotropes, and an intra-aortic balloon pump. You may also consider treating any concomitant heart failure, and then in acute severe regurgitation, surgery would be indicated. And repair is preferred over replacement in degenerative regurgitation. It's just associated with lower mortality and higher survival rates. So mitral prolapse is sort of the last valvulopathy I'm going to cover. This is often known as Barlow syndrome, and it's a type of valve disease in which the flaps or leaflets of the mitral valve actually become quite enlarged or stretched. And then these enlarged flaps will then prolapse into the left atrium whenever the heart contracts with each heartbeat. So it's mostly idiopathic. Generally, there can be things that kind of weaken the leaflets, or they increase the leaflet area, or they elongate these chordae tendineae, which hold the mitral valve to the papillary muscle here. So all of these things can predispose someone to developing mitral valve prolapse. Here are some associations. Tends to occur in young women. History and examination-wise, it tends to be asymptomatic, or you may see atypical chest pain or palpitations. There's a mid-systolic click with or without a late systolic murmur. And then complications can include mitral regurgitation. So basically, if it's so bad that blood is now moving back into the left atrium, you may develop mitral regurgitation. Systemic emboli can also occur, arrhythmias, which are kind of associated, and then sudden death as well, particularly given how they're predisposed to developing emboli. Investigations, there's diagnostic investigations include the echo, so this would show a prolapse of the valve cusps, either one or both, and then ECG, typically normal, but there are some characteristic changes. You don't need to know too much for exams, but it can show inferior T-wave inversion. Management generally tends to be similar to before, so if someone is having chest pain, palpitations, or basically symptomatic, you'd consider beta blockers. Anticoagulation if there's significant mitral regurgitation and AF, and then surgery you'd consider if there was very severe disease. So I'm going to skip the SBA for the time being, but if anyone would like the explanation, I'm just going to go over it now. So this basically was a very textbook presentation of rheumatic fever. And so rheumatic fever, as mentioned earlier, can cause loads of different types of valvulopathies, but here it's causing this early diastolic murmur. And the reason why this is aortic regurgitation is because in diastole, the blood has basically been ejected from the ventricles, and it's sort of gone through those aortic and pulmonary valves, and these are not supposed to be closed. But if the valves are leaky, an early diastolic murmur is going to be heard because the blood is moving back from the aortic arch to the left ventricle because of this incompetent valve. Okay. So I'm now just going to review myocardial disease. So myocarditis is inflammation of the myocardium. It often tends to present with pericardial inflammation, also known as myopericarditis. It tends to affect young people, so people from 19 to 35 years of age. This is just an overview of what the heart wall actually looks like. So you can see that the pericardium has two layers, and there's fluid over here, and then the myocardium is a very thick muscular layer that facilitates contraction. So Myocarditis tends to be viral, but it can also be bacterial. And so Coxsackie B is the virus that tends to cause myocarditis, which can then progress to dilated cardiomyopathy. So the most common cause of death in RF tends to be myocarditis. And as Shazmen mentioned before, myocarditis, which happens secondary to rheumatoid fever, is associated with Aschoff bodies, so the granulomas with the giant cells and the fibrinoid material. It can also be associated with Anischkow cells, so these are reactive histiocytes, which have these wavy, slender nuclei. So history and exam, these are characteristic signs and symptoms that may present. Pericardial rubs may occur in myocarditis. So this is where there is fluid now presenting in the pericardial sac, and heart failure can also occur if there's fulminant disease. Investigations you'd consider include ECGs, cardiac enzymes, viral serology, also imaging, so chest X-ray, echo, cardiac MRI. The gold standard is endomyocardial biopsy, and this is where you take a small amount of the myocardium and look at it under a microscope. And so this is what an example of the biopsy looks like, and this is just showing very extensive infiltrate of eosinophils into the myocardium. And then the ECG in particular, it may show non-specific changes, but the leads that are involved may suggest the location of the myocardium which has been affected. And the symptoms, generally speaking, will just depend on what is actually causing the myocarditis, as well as how much inflammation there actually is. Okay, so just moving on, the management is going to be generally quite supportive, treating the underlying cause, any complications. There's a role for steroids if it is viral. NSAID use, however, is controversial, and exercise may precipitate arrhythmias. So generally, patients are advised to limit activity for a few months. Prognosis is is okay. So about half recover within 4 weeks, but many can develop complications such as heart failure, dilated cardiomyopathy, and arrhythmias such as long QT syndrome. So just so you're aware, it's not always, sometimes there can be a positional component to myocarditis. So sometimes it can be worse on lying down, sitting upright, but this is variable. Now, pericarditis, on the other hand, again, very similar causes to myocarditis, and I just wanted to bring your attention to the pericardial rub. So in pericardial effusions, there's excess fluid actually accumulating within the pericardial sac, and then cardiac tamponade can result when the pressure in the pericardial sac is the same as the pressure within the cardiac chambers. And so you can get this VEX triad, which is characteristic for cardiac tamponade, particularly in SBAs. So low blood pressure, raised JVP, and muffled heart sounds. And if it's constrictive, you may also have Kussmaul sign. Investigations, ECG will show this widespread saddle ST elevation and PR depression. You may consider serial troponins, inflammatory markers, viral serology, and then imaging-wise, you would want to look into echocardiogram and angiograms as well to rule out other disease. ECGs may the changes that happen with pericarditis evolve over time. So initially, within 1 to 3 weeks, there's a normalization of the ST changes. The T waves tend to flatten. From 3 to 8 weeks, the T waves will then kind of invert, and then from 8 weeks onwards, it will tend to be normal. So this is a relatively, this is a point that's not necessarily specific to pericarditis. When you're looking for ST elevation, you need to be looking at the J point. So this is a point from the QRS complex to the ST segment. And this needs to be the point at which you compare to the baseline. And so this kind of shows you that there is indeed ST elevation, but it is something that can be easily caught out. You can get caught out on in exams. So just very quickly moving on, with regards to management, if you have sort of idiopathic or viral pericarditis, you want to consider exercise restriction, NSAIDs, and always co-prescribe PPIs with NSAIDs. This is for about 1 to 2 weeks. And then colchicine, an important side effect of colchicine is diarrhea, so you'd also use it in caution with people who have renal or hepatic impairment. And then you'd also consider steroids for people who can't tolerate or are refractory to NSAIDs. And then bacterial, you would consider IV antibiotics, pericardiocentesis, potentially if there's purulent exudate. And then non-infective pericarditis, you would want to consider steroids. So now very quickly moving on to dilated cardiomyopathy. So there are loads of different types of risk factors. Alcohol is one that's commonly assessed in SBAs, and this is a useful mnemonic to remember the different causes. And then on examination, it's likely to have you'll have a displaced diffuse apex beat because there's increased volume in that ventricle. S3 gallop, so S3 again is due to rapid ventricular filling. Arrhythmias may occur, and there may also be a systolic regurgitant murmur, and this is the most common type of cardiomyopathy. Investigations, very similar to below, but the echo will show globally dilated hypokinetic sort of ventricle with a reduced ejection fraction potentially. You'd consider further investigations accordingly. And then on chest x-ray, this is sort of the characteristic sign. So you have the balloon appearance where there's enlargement with potentially pulmonary edema. Pleural effusions can be seen in some patients. So generally, it's the left ventricle that tends to be more affected in DCM. Oops. Okay, so in ECG, you can have very non-specific T-wave changes, poor R-wave progression from V1 to V6, but this isn't necessarily diagnostic. And then management, I'm just going to let you guys read this and feel free to let me know if you have any questions about that. And so when it comes to Takotsubo cardiomyopathy, this is just a very sort of unrelated kind of point, but this is what you might have encountered. It's known as broken heart syndrome, but it is also something that can occur in periods of very high stress. So things like sepsis, for instance. It's a very rare acquired primary cardiomyopathy, and this is where you have a very transient ballooning of the ventricle, and it kind of looks like this octopus on imaging. So patients can present with chest pain, heart failure, ST elevation, but the coronary angiogram may be normal, kind of ruling out an MI, and then management is generally supportive. And then hypertrophic cardiomyopathy is a very leading cause of sudden cardiac death in the young. Generally tends to be autosomal dominant inheritance, and these are the proteins which are most commonly affected. It's really important to take a good family history, ask about sudden death. Background-wise, there's usually an asymmetrical left ventricular hypertrophy, which includes the septum, and then this in turn kind of obstructs the outflow tract from the left ventricle, and then this then can cause concentric hypertrophy, which can then result in diastolic dysfunction, and then history-wise, again, very similar symptoms to before, but just to note, there's a sign of the S4 also occurs, and the way to remember this is just by remembering that HOCM has 4 letters. You may also pick up a jerky pulse, large A waves, double apex beat, and ejection systolic murmur as well. And this is just on biopsy, what you might see, and this is just a schematic, just giving you an overview of what is actually happening. Okay, so investigations, generally ECG and echocardiogram. This is a useful mnemonic to remember what the different features are. This is weirdly tested quite commonly in exam questions, so something that's just good to know. And then ECG, you'll see non-specific changes, LVH. So as mentioned earlier, so these are the tall Cures complexes. You'll see quite high R waves. Again, you can look at the Sokolov-Leon criteria for the specifics on that. And then management, a good way to remember is ABCDE, although this will generally vary. So arrhythmias, you'd want to treat with amiodarone. If there are any paroxysmal AF, emboli, anticoagulate. If there's reduced ventricular contractility and symptoms, consider beta blockers or non-dihydropyridine calcium channel blockers. And then more surgical interventions, you may consider our ablative septal myomectomy or potentially an ICD or dual chamber pacemaker. Importantly, it's very just avoid nitrates, ACE inhibitors, and inotropes. And then restrictive cardiomyopathy. So this is, again, a common sort of exam topic. Amyloidosis is a key cause, and then there are many other causes. I would recommend looking at QuesMed for a good list. There are different subtypes of amyloidosis which can actually affect the heart, but something that's often seen in the SBA stem is apple green birefringence, and so that's with Congo red staining and looked at under polarized light. So that's what that looks like, and so that would suggest a infiltrative cause of this restrictive cardiomyopathy. And then on presentation, you'll see many different signs and symptoms, and about 75% of patients will also have atrial fibrillation. So I'll let you guys read the investigations. Just want to bring your attention to sparkling appearance due to infiltrative disease sometimes, and the gold standard would be cardiac catheterization. And usually you'd want to just treat the underlying cause and consider symptomatic relief, as well as treat any potential AF that might be occurring. Okay. Okay, so SBA 10, so this is just a very common exam question. I'm just going to go over the answer now. So this is a 21-year-old athlete who has an ejection systolic murmur. In this case, the person has an ejection systolic murmur, and the most common cause of sudden death in HOCM is just ventricular arrhythmia. This is a very commonly tested fact in SBAs, so just a good thing to know. And I'm now going to move on. So feedback form if anyone in the recording wants to give feedback, but thanks so much for your time. That's the end of the tutorial.